Good morning all. I'm Rohit Kotade. I'm working as a product executive at Derma. Welcome you for the DADI, Dermapath Academy and Diagnostics India Private Limited. First of all, I would like to thank you to Dr. Sasi sir, Dr. Manoj sir and Dr. Nandakumar sir to giving an opportunity to present here. So present analytical real-world dermatopathology cases and educational support by Derma. Now I would like to introduce about our Derma. So Derma, we have a core purpose that is elevating life and the core values that is meaningful innovation, unwavering commitment to the quality and safety, continuous improvement and result through teamwork. And we have an aspirational core value that is customer success above all else. Derma have a launch first time India in product 7 plus and 400 plus enterprising Dermians. We have a 130th ranked pharma company in country and 700 plus distribution network. Derma have a 9,000 plus associated dermatologists and we have a skilled R&D team and develop innovative products. So Derma have a product mix like a antifungals, moisturizer, acne care and hair care. Along with that, we have a psoriasis care, topical steroid, vitiligo care and nutraceuticals. So Derma have India's first company to make all product paraben free, sulfate free and detergent free. So Derma have a patient safety is a paramount concern. Now I would like to introduce our flagship brand that is Moist, the most advanced moisturizer and cleanser. In Moist, we have a Moist cleansing lotion, Moist Syndet bar. Along with that, we have a Moist LMF 48 long lasting moisturizing formulation. And along with that, we have Moist XL. We have a Moist MM and Moist cream. Along with that, we have a Kiran range that contains ketoconazole. Kiran, the advantage of solubilized ketoconazole in lipid phase. In Kiran, we have a Kiran Stay On lotion, Kiran soap, Kiran zip, Kiran cream, and Kiran tablet. Recently, we have a launch MinoBoost range in new avatar. MinoBoost, the complete hair regrowth therapy in the management of early stage androgenic alopecia and advanced hair loss. In MinoBoost, we have a MinoBoost 5 which containing minoxidil topical solution USP 5%, MinoBoost F5 which containing minoxidil 5% and finasteride 0.1%. We have MinoBoost F10 which containing minoxidil 10% and finasteride 0.1%. MinoBoost Progen which containing minoxidil 5%, finasteride 0.1% and Procapil. We have a MinoBoost range with the spray applicator and dropper, and along with that we have a educational support with the QR code. Also we have a oral therapy that is MinoBoost 2.5 mg tablet. Derma is India's first company who is launching ozonoxacin molecule, which is novel non-fluorinated topical quinoline. Ozodex, which available in cream and lotion form. So Derma have a Sanosun baby, which is a tie-up with a made in German brand, the brand Premium Pediatric Skincare. So Derma have a tie-up with a Man and Shoulder company, which bring world-class derma tested, certified, and natural and safe baby skincare product to Indian mothers. So Sanosun baby, German's premium baby skincare, one global, one formulation, 14 plus years of expertise in baby skincare and presence in 70 plus countries. So Sanosun baby gained the trust and confidence of 250,000 plus Indian mothers. Sanosun baby made with a more than 90% natural ingredients, 0% SLS and SLES paraben free product and clinically tested hypoallergic. So Sanosun baby with a milk protein and organic olive oil. So that's all about the Derma. Thank you so much, all of you. Thank you. And I would like to hand over session to Dr. Sasi sir.
Thank you very much, Rohit and the Derma team for facilitating this. So at the outset, I'd like to welcome Dr. Ramalakshmi madam, who's my teacher in medical college when I was studying. She was she was the pathology teacher for us. She was at that time and then became professor, and she served as a professor in a number of medical colleges across Andhra Pradesh. So she's contributed 2 cases to this quiz this time, and welcome on board, ma'am. And then we have Dr. Nandakumar sir and myself, and Dr. Manoj Singh sir. Unfortunately, he is in the UK, and he may, if he wakes up in time, he'll join in. And I'd also like to welcome Dr. Lavanya and Dr. Shika, who are the winners of last time's quiz. So congratulations, both of you, and welcome on board. So I'll hand over the remaining session to Nandakumar sir because most of the cases are his. The first two cases, however, are Dr. Ramalakshmi madam. So, madam, if you want to join in, you can certainly contribute because the first two cases are yours. So I'll just share my screen. And maybe Dr. Lavanya and Dr. Shika, if you don't mind, we'll just basically get you to share the findings of the cases, and then we'll see what the others have scored them and take it from there. So we'll quickly move on to case one. Case one is the history given was 21-year-old female. Anybody want to speak? Sorry. Okay. So the case one is a 21-year-old female with a slowly enlarging crusted papillonodal lesion in the scalp since childhood with occasional serious discharge. And this is the histology. Let me just orient it properly. So yeah, Dr. Shika, since you've been waiting for a while, you've joined early. Do you want to
Yes.
describe the findings here, please?
Sure, sir. I cannot see. Will I be able to see the histopathology slide?
Can you
Or
not see
So,
the,
I cannot see, sir.
is my screen not shared?
no, I can see it.
I can also see.
Dr. Shika, have you not zoomed in? I mean, have you not seen the full screen? Are you just seeing your profile video, maybe?
No, I'm seeing all of you. I can see you, sir. I can see
Are you on the
Nandakumar, sir.
phone? Maybe you rotate the phone horizontally. Maybe that may help. I don't know. Maybe you're
I
viewing.
can see it now, sir. I can see it.
Yeah, yeah.
Yeah, I
So,
can see it.
yeah, maybe you want to describe the low power appearance of it, see what you notice of it, and then slowly progress.
Yes, sir. Yes, sir. What I see here is skin with epidermis and subcutis. The epidermis shows basket weave orthokeratosis, mild acanthosis, and at one edge of the biopsy, I can see a crateriform lesion with some papilleroid projections. And
Okay, please be relaxed. This is strictly an informal discussion. Please be
yes,
relaxed. You can take your time and just do it calmly, please.
yes, sir. And like a crateriform lesion and like some projections which are coming out of it, and then I can see the subcutis with a lot of hair follicles. In the middermis some sebaceous units are there, so the lesion is from the scalp.
Yes, so that's even without the history, I guess you can tell the lesion is from scalp just given the number of hair follicles, isn't it?
Yes, sir.
And do you think the scalp biopsy itself, the whole biopsy is a normal biopsy apart from that bit where you describe the crateriform lesion, or is there any pathology in the rest of it?
In the
There not
rest,
be. I mean, I'm just giving you a trick question, so don't worry about it. Just tell
in the
what you.
rest of the lesion, I feel it's looking quite normal for me. Some sebaceous units are there which are there in the middermis. I think the hair follicles look normal, so
Okay, excellent. So maybe I'll just go and hire part. Dr. Ramalakshmi, madam, are you there? You want to
Yes,
come?
I am here.
Okay, madam. So you may want to join in the discussion. So Dr. Shika here is describing the findings. So you can feel free to interject as and when you feel, madam. Okay.
Okay.
So Dr. Lavanya, here's the higher power. Maybe you want to comment on this here.
yes, sir. Um, Here on high power, I can see a lesion um, which is showing these projections, and these projections are lined by a double layer of cuboidal and columnar epithelium. And at places, I can see some squamous metaplasia, I think.
Where do you think there is a bit of squamous metaplasia? Maybe I'll
Not
go
here
low.
in this focus, but in one of the focus, I had seen it. So.
Okay, I'm not quite sure. Okay, maybe you're talking about this bit,
Yeah,
maybe?
yeah. Yes, yes.
Yeah, I guess so. Yeah. Okay.
And then double layer of cuboidal and columnar epithelium, and these And the stroma of this lesion is comprised mainly of dense lymphocytic infiltrate admixed with many plasma cells.
Yes, excellent. I think that's an apt description. Dr. Ramalakshmi, madam, do you have any other findings that you wanted to discuss?
I think there are some sebaceous glands more below
Yes.
the lesion.
Yes.
Can it be a sebaceous nevus associated with the syringocystadnoma papilliferum? Can we think of that possibility also?
Yes, ma'am. Because the lesion is present there since childhood, uh, that can be thought of. These are usually seen together. But in this particular case, I didn't think of nevus sebaceous associated.
Yeah, you thought this was a normal number of sebaceous glands and follicles within the scalp.
Follicles are fine. I thought that some sebaceous hyperplasia is there, but I didn't find the alopecia patch underneath the.
Yeah. What do you think we should find to call this a sebaceous nevus?
We should find a. We should find the loss of hair follicles underneath. The sebaceous unit should open directly into the epithelium, and then underneath there should be a patch of loss of hair follicles underneath.
I think that's I think that's excellent. Dr. Nandakumar sir, do you have anything to add?
I thought it was syringocystadnoma papilliferum alone. The large number of sebaceous units, I attributed it to the anatomical site. The
Yes.
mild epidermal hyperplasia could be part of this syringocystadnoma papilliferum. What was the age of the patient?
I didn't have the history, so I put in 21. But ma'am, you probably can chip in here, Ramalakshmi madam.
Maybe around 28 or female.
28 female, right? And did you think this was nevus sebaceous, madam?
Initially, I haven't thought of. Just after seeing the slide again, I had a doubt. Initially, gave it as only syringocystadnoma papilliferum. Actually, there were two sections, and one section did not show anything. And gradually, after searching the slide, I could find this beautiful area, which is very characteristic.
Yes, yes. Unless that's the reason I think you need to do multiple levels, and it's important to thoroughly exhaust a specimen if you don't have pathology in the initial sections. I think that's an important learning point, madam.
Actually, what I feel is dermatologist should know the dermal pathology. So if he gives the differential diagnosis as a pathologist, we'll try to analyze, give the histopathology. Sometimes with experience, we can give a good diagnosis, or we have to put differential diagnosis and leave to the dermatologist for his clinical correlation.
Absolutely, madam. History is very important. Absolutely. History and a clinical picture you have.
We are not good at clinical dermatology. Only few cases routinely what we see, we know. But
Yes.
rarer things, we have to depend on your diagnosis only. So that's why we give the description mostly. And if we are very confident, we give the diagnosis.
Absolutely, madam. So actually, it's a good to have your opinion as well, madam, because Dr. Nandakumar sir is basically a pathologist and a dermatologist. He's trained in both. He's got an MD in both, and I am a dermatologist with pathology interest, and I've got a diploma. So it's nice to have a pathologist alone. So we have all different views here. And Dr. Shika is a dermatologist, pathologist, and Dr. Lavanya, you're a dermatologist, right? You're there.
No, sir, I'm also a pathologist.
You're also a pathologist. Sorry, I forgot. So yeah, it's a full-on pathology house then today.
So can I add one point? Like
Yes.
just beneath the lesion of syringocystadnoma papilliferum, you can see dilated apoepocrine glands. And that is a clue to the diagnosis of nevus sebaceous. I thought of both lesions in this. Dilated apoepocrine glands
I
are
am
there.
not sure. Yeah, that Nandakumar sir and Ramalakshmi
Terminal
madam
hair follicle is lost in this area, I felt. Like towards the end, towards the left-hand side. The terminal follicles are not there.
The point is well taken, but the apocrine lobules that we are seeing to me, they appear to be normal rather than, as you said, dilated. We do see dilated ducts beneath the lesion of nevus sebaceous. You are absolutely right. But this appearance, I thought that, especially, it occurs on the scalp in a young patient. I thought it was only part of the normal histology. To me, if I were to sign off the report, I would stick to the syringocystodema papilliferum alone. I mean, it is open to debate, but still, that is my opinion.
Yes, sir. I would agree with this actually, because I didn't think that was abnormal. I thought that was normal too. Right.
Am I part of the meeting?
Oh, Manoj Singh,
yeah,
welcome.
great.
Good morning.
Great.
Great to have you here.
Yeah, I don't think I would see any elements of nevus sebaceous in this. I think this is just a scap, or if it is a nevus sebaceous in which a scap has arisen, that is, at least in this slide, it's not visible. So
Yes.
I would just go ahead and call it a scap, as Dr. Lakshmi has done, and because in this, many times you do see different elements of nevus sebaceous apart from the scap. And in this, I don't think that is enough for
Excellent.
nevus sebaceous into which a scap has arisen.
Excellent.
Besides which, I think, if I may say so, this is a young person and a biopsy from the scalp or the face, actually, because, I have seen scaps arising on the face and the forehead and all also. And young person because the hair shafts are black. So,
Okay. And yes, obviously we need to completely excise the specimen and take it from there. But on this biopsy, I think scap enough alone is the diagnosis, right? So
yeah.
let's go to the answers. So there are 38 participants this time, which is the average number we've had so far. So 10 of them have called it syringocystoma papilliferum. I think we're giving them 1 point. Now, 4 of them have called it nevus sebaceous with syringocystoma papilliferum. I'm giving them point to. They've called it. They've named it syringocystoma papilliferum, so they've not missed that. They've just added an extra diagnosis. So how much are we giving them for miscalling it, or also diagnosing nevus sebaceous?
I
We
don't
give
think
this
there is
mark?
evidence for a nevus sebaceous in this. So that would be a little bit of a guesswork. So I think you should give less than 1.
Half mark, I think, would be justifiable because they've got half the answer correct. Nevus
Yeah,
sebaceous
yeah, I
is
think
not
that's
right.
fine.
Yeah. Nandakumar
I
sir, are
think
you
that's
okay
fine.
with half or do you think?
Yeah, 0.5. 0.5.
0.5, yes. What about Yadason's nevus?
No.
No. Trichoepithelioma, congenital nevus sebaceous. I don't know why that's in the list, but that's again no. There's no nevus sebaceous there. There's no seborrheic keratosis. Dissecting follicle. I don't know where that came from. Atypical. I'm not sure. I guess the bit of the metaplasia, epidermal metaplasia that Dr. Shrika was referring to earlier. Somebody used that and got confused and called it atypical, but I'm not sure this is atypical.
No.
No, this is not atypical.
Yeah. Payal cyst, bullous pemphigoid, verruca vulgaris, tricholemous cyst. So yeah, I think we're submitting it as it is. So we've got half mark for nevus sebaceous with syringocystoma papilliferum and 1 mark with syringocystoma. Okay, excellent. So let's go to the second case. Again, this is Ramalakshmi madam's case. This is a 38-year-old male with multiple itchy erythematous plaques with superficial pustules over the trunk and limbs for 2 weeks on a background of chronic scaly lesions over elbows and knees. So he's got a chronic problem and then he's got an acute problem. And this is a biopsy, obviously, from the acute problem. So Dr. Lavanya, maybe you'd want to discuss this case?
Yes, sir. So in this scanner view, I'm seeing a skin biopsy, which is showing marked psoriasiform acanthosis with scaled crest.
Can I just interrupt there? On what basis did you call it psoriasiform?
It is like irregular, like it is like downward elongation of the reti ridges, but because of the bad orientation, it looks like interconnected.
Yes.
The
So
thickness is increased.
on this section, you cannot call it really psoriasiform. You can only comment that this is a cross-cut specimen. Is that not true?
Yeah. Yes, sir.
I think you've gone to a diagnosis and then you're describing histopathology based on that. It should not be that way because
Okay.
then you're prone to bias and presumptions. This is a cross-cut specimen. Yes, this may be psoriasis. But then
But
on this histology alone, I think it's difficult to call it psoriasiform hyperplasia, which is not what juniors and dermpath novices would understand as psoriasiform hyperplasia on this one.
But the best that we can call it is there is epidermal hyperplasia, perhaps, not
Yes.
Yes, sir.
psoriasis.
Yes. Acanthosis with an oblique cut.
Go on, please.
So epidermal hyperplasia with scale crest at multiple focus, I can make out.
Yes. And we go slightly higher power, maybe. Yeah. So for people who don't know, what are all these, Dr. Lavanya, you probably want to explain what are all
These
these.
are the dermal papillae which are in cross section.
Yes, absolutely. So we need to not every the reason I put up this slide. It's a beautiful slide by Dr. Ramalakshmi madam. Normally we see psoriasis and pustular psoriasis or whatever we want to call it. It's a nice section that we see, but sometimes you get cross sections and you still should be able to make a diagnosis, right? And this is a
Yes.
nice cross section, and this is showing the dermal papilla coming through because you've cut the epidermis more or less horizontally, right? And then, yes, please go on and describe the remaining features.
So I can see neutrophilic infiltration in the scale crest, making it a Monroe's microabscess. I can also see suprapapillary thinning. The dermal papillae is very close to the stratum corneum at places. And I can also make out spongiform pustules of Kogoj.
Okay. Spongiform pustules of cockroach, probably it's difficult because it's a cross section. You don't know what is a dermal papilla and what is not. But yes, I agree. There are a lot of features. Anything else?
Can I make a comment?
Yes,
See,
sir. Please.
I think, especially for beginners in dermatopathology, the two terms, one is scale crust and the other is what is seen here. This is actually a parakeratotic neutrophilic abscess. That is what we are seeing here. That has to be differentiated from a scale crust,
Yeah.
which contains dried up exudate, which clinically also it shows crusting. It is dried up exudate with intact or karyorectic neutrophils, hyperkeratosis, etc. So we shouldn't use one for the other. This is, to me, a typical parakeratotic neutrophilic abscess, what we call as Monroe abscess. This should not be termed as scale crust. That is different. That is seen in any acute spongiotic dermatitis, scale crust.
Right, sir.
Yes, please.
So, Dr. Lavanya, what is your diagnosis in this case? Do you have any findings?
Pustular psoriasis in this
Pustular
case.
psoriasis. Yes, excellent. Ramalakshmi madam, did you have anything else to add?
I had the opportunity to see the clinical photo also. So something like rounded lesions, some sort of scaling was there. Initially also I was a bit confused because of so much of acanthosis and irregular section cutting. But gradually, after seeing all the slide, I came to the diagnosis of pustular psoriasis. Because you can see the edematous stratum malpighi with collections of neutrophils and even parakeratosis with microabscesses. So I thought it is only pustular psoriasis.
Madam, did you do a PAS? Did you think it was necessary or did you not?
Pardon?
Did you do a PAS stain? Did you think it was necessary in this case or you did not?
No, I didn't think of fungal infections or anything.
Okay.
So,
but I
was
guess
very sure because of the picture, it should be psoriasis.
Yes. But sometimes I think I guess it depends on the clinician if it's clinically indicated. But sometimes we do get it's very rare, but we do get tinea associated with psoriasis, in which case you get pustulation as well. And
Yes.
I've seen a couple of cases. So I personally think it is if clinically, obviously it depends on the clinician what they're thinking. If they have that in the differential, then doing a PS in these cases is not, out of the way. I think it can be considered. Okay. Anybody anything else to add? Manoj Singh, sir?
What you're saying about PAs, actually, I've been seeing PAs in a lot of places, fungus and tinea, in a lot of places where it actually, is not even suspected. So, in a case like this, it would actually be a kind of a curiosity. And the other thing I would suggest is, what I have over the past year in my labs been trying to do is to switch on to a PS diastase, because that I mean, this of course something which we have been doing for so many years, but a PS diastase actually, because many times I am seeing now in my labs that the PS is not all that. The PS is not all that, it's very hyper and all that. So if you do a diastase, then diastase will wipe out a lot of the background, and tinea bodies will stand out very well. So I am, as a routine, actually suggesting to my labs that you please just do PS diastase in all the cases where I'm asking.
That's interesting, sir. Maybe you could share some pictures of PAS and PAS diastase together,
Yeah,
and
sure.
show us the difference next time.
As soon as I come back.
Yes, sir. Excellent. Okay. So we'll move on quickly to the answers here. So let's see what people have answered. So case 2, there are 27 people who called it pustular psoriasis. We're giving it a straightaway 1. Somebody has called it subcorneal pustular dermatosis variant of IgA pemphigus. I don't think we can make the diagnosis here given the clinical and everything else.
No.
Though it is in the differential, but I don't think we can call that. Psoriasis vulgaris, but I don't think, I'm not sure we should be giving that any marks, because I think based on the history, people know, the clinician knows it's psoriasis vulgaris. They're looking for a pustular variant of it, and I'm not sure. Should we give it any marks? Some marks? There are some psoriasis features, so they maybe pick that out. So 0.5 or no marks?
So 0.25.
0.25, right? Okay. Sir, Manoj Singh, sir, are you a bit more liberal, or 0.25 is okay?
I'm okay with what you guys are saying.
0.25, okay.
I think, I mean, this is, common or garden psoriasis is pretty okay. 0.25, 0.5, whatever, as long as the person has identified this as a psoriasis. But, there are some more kind of.
We've given the history. I mean, we've told them that the patient has extensive lesions for a long number of years.
Yeah.
We're not looking for a diagnosis of psoriasis, obviously.
Yeah.
So then there's mycos fungoides. I don't think we can call it that. Guttate psoriasis, again, if I'm not sure where guttate has come from. So giving it 0.25, again, should we give psoriasis here 0.25?
No, they have specifically called it as guttate psoriasis. That's the wrong answer. I don't think we should.
Okay, fine. Then again, acantholytic dyskeratoma, palmoplantar pustular psoriasis. Again, it's not palmoplantar, so no chance of that. Atopic dermatitis, drug-induced subcorneal pustular dermatosis. So, would you consider that drug-induced? So maybe they were on drugs, and I mean, he's gone to a lot of imagination. This person, whoever has given that.
No.
We've not given any history to suggest that.
Actually, drug reactions can cause anything, any morphology, any histology.
Yeah.
But, in this specifically, I mean, okay, you want to call it drug-induced psoriasis and so on and so forth, that's different.
There has to be a history to support it. I mean, it's probably in the differentials, certainly, and so is tinea. So somebody has also mentioned tinea number 10, as I've said. But again, that's in the differential, but you can't call it that.
No, because tinea you need to see.
Sorry, sir?
If you see tinea, then you call it tinea.
Yeah.
We are not seeing any fungus, no?
Yeah, absolutely not. So, none of the other answers getting any marks, so I'm submitting this.
And incidentally, supporting that last diagnosis, I would like to add that there are situations when you can, if you look very hard, you can actually make out tinea in HND also.
Oh, absolutely.
And just one particular thing which one needs to be careful of, in this kind of a thing, I think there's no issue in calling, I mean, anything can look like tinea here. in the cases where you get a nice clean biopsy, which, I mean, it's actually almost like normal skin, and there is just only hyperkeratosis, kind of lamellar, little bit hyperkeratosis. You do a pass, and you see the fungus. Then you go back to the HND, and there are situations where you can make out the fungus in the HND also. And I'm not saying that every biopsy you look carefully at the
Yes.
keratin layer, but the point I'm making is that at times it is visible in the HND also.
Yes, same
Because,
applies to
the
even
fungus,
pityriasis versicolor, sir. A number of cases I have in my
yeah,
collection where pityriasis versicolor was obvious on H&E itself. And in fact,
yeah,
recently in our Dermpath WhatsApp group that I have, I shared a case of Madura foot where it's a eumycetoma, where actually the mycetoma within the granules, you can see the fungal hyphae, even on
yeah,
H&E,
okay.
which was
Yeah,
actually quite amusing.
I think the learning point is that one should spend time looking at the stratum corneum.
yeah.
One has to spend time.
Yes, yes. I mean, you need to be enthusiastic about what you're seeing. You need to appreciate each and every finding. Look at, be excited about it. And all these, I think, are, you can't really teach them. These are something that are innate. They have to come, they have to be there in someone. So case number 3, Dr. Shika, maybe you want to comment on this. 50-year-old female with painful erythematous plaques over face, neck, and upper limbs for 10 days, associated with low-grade fever and malaise, no history of arthralgia or preceding infection. Okay, so this is case number 3, and here's your low power.
Okay, I can see the epidermis and the dermis with scanned subcutis, and the epidermis looks, I think mild acanthosis is there, and then underneath that there is a nodular infiltrate, which I can appreciate.
Yes. I mean, acanthosis, I think, is very difficult, I think, to comment at this stage, because if you look at the entire epidermis, this is a large biopsy, and the
Okay.
epidermis is more or less uniform throughout. I mean, not it
Okay.
doesn't look anything different above the infiltrate. So it depends on the site, isn't it? It depends also on the
Yes.
site of biopsy. And
Okay.
then we've told you it's an acute lesion. Acute lesions generally, unless it's psoriasis, epidermal changes are usually rare, isn't it?
Yes, sir.
Usually they take time to develop. But yes, they may be a little bit maybe here compared to here, but it's difficult to comment. Yes, okay. So this is the higher power. I'll just go up so you can see the infiltrate, etc.
Yes, sir. So in the dermis, I can see uh, dense infiltrate mainly composed of neutrophils and
Yes.
maybe occasional lymphocyte here and there. Predominantly, it is composed of lymphocytes.
Dominantly neutrophils. And yes, you were commenting on the epidermis here. Is there any epidermal change here that you want to comment on specifically?
Minimal spongiosis, I can see, sir.
Yes, yes. Agree.
Yes.
Nandakumar sir?
Yeah, there are extravasate RBCs in the
Yes.
papillary dermis.
Yes, sir.
The
Extravasate
dilated
capillaries.
capillaries are there.
Yes, sir.
Dr. Shikha, does that signify anything? Does that mean anything to us as pathologists? Do you think that's something that we
Uh,
take note of? Does it imply any disease?
Yes, sir. When I'm seeing a lot of neutrophils along with extravasated RBCs and some dilated capillaries, minimal endothelial swelling is also there. So we should look for vasculitis if any fibrinoid necrosis is there in the vessel walls. But I didn't find any fibrinoid necrosis as such in this case, sir.
Can we go to the deeper portion at this site? Lower dermis are where? Can you just here? Can we just go to a hypo?
You're talking about this vessel, sir?
No, just slightly higher above where there is lot of extravasated RBCs are seen.
Oh, here?
Yes. I think we should focus on that area. Plenty of extravasated RBCs, but as Dr. Shiga said, I couldn't make out any fibrinoid necrosis as such. Carrier
Yes,
excess is there.
yes, carrier access also is there. So, but fibrinoid necrosis, we couldn't appreciate.
I think we could spend a lot of time arguing whether fibrinoid necrosis is a must to make a diagnosis of vasculitis in
Yes, sir.
skin lesions.
Yes, sir.
I would like to hear from Dr. Manoj Singh whether
One
fibrinoid
issue,
necrosis is a must.
one issue is, of course, that when you are having such a fairly extensive inflammation, then you always have that, whether a donkey came first or the camel. This is actually incidental vasculitis, which is part of some other inflammatory process, or that this is kind of actually a vasculitis which is very, very extensive, and the inflammation is part of that vasculitic process. Because whenever you have, I mean, obviously when you have RBCs extravasated to this extent, there is considerable vasculitis going on or vascular damage going on. Now, whether that is associated with fibrinoid necrosis, yes or no, I would find it a little difficult to kind of carry out that argument, because I'm a vasculitic process which is involving all the way from the upper dermis to the lower dermis, and maybe even in the panicles. I find it a little difficult to kind of discuss that case as far as diagnosis is concerned.
I think one more thing about against vasculitis maybe is the just a sheer amount of intensity of the infiltrate. Normally,
Yes.
if we don't see such dense nodular infiltrates in pure vasculitis generally.
Yeah.
And given the amount of infiltrate, the vasculitis has to be secondary in that context.
But I mean, like, nodular, yes, if you have one of the medium-sized or larger vessels in the lower dermis of the panicles, and that is associated with, an extensive inflammation around it, and the chota vessels are actually being, damaged and inflamed because of that. But then you would see, something in a larger vessel. But here, what you're seeing is actually, you don't see a larger vessel. You are seeing just, these little bit small vessels, which are, also associated with the RBC extravasation. So I find it a little difficult to, kind of opine about this case.
Just
It's
out
an
of interest,
acute process, isn't it? It's an acute lesion.
yes,
Well,
I
yeah, because RBC extravasation is there. So whatever it is happening. I mean, RBC extravasation will not continue for weeks and weeks. So you're seeing it, that means it's ongoing.
Yeah.
Yes, and we see RBC extravasation even otherwise in any acute lesion. So that alone, even pityriasis rosea, psoriasis, you may see
Yes,
RBC
yes.
extravasation.
Yeah.
Michael exanthems, you may see RBC extravasation. So
Agree.
that alone should not be a factor. What about the eosinophils? Did you think much of them?
Few are seen. I think a significant number I wouldn't commit. Few eosinophils are seen.
Okay. Dr. Shika, did you make a
Yes, sir.
diagnosis based on this one? Were you able to?
Sir, I was thinking more on the lines of sweets.
Excellent. I think
that
that
is
was what Dr.
I
Nandakumar said.
think a neutrophilic dermatosis is a distinct possibility. I agree.
Yes, good thought.
Given the eosinophils, does that point towards a drug, sir? Do you think that is a possibility that did you raise that possibility given the few eosinophils, or would you not consider the eosinophils?
Yeah, this field actually shows more than few. It's quite a good number in this field. Towards the left-hand side, we are seeing at least 1, 2, 3, 4, 5. Quite a few are seen. Probably drug-induced.
Yeah. So that I think is a possibility one can raise if they're seeing eosinophils, though it's not a hard and fast rule that you should see eosinophils in all.
Yes, I think here comes the point of CPC also. Discussion with the clinician.
Yeah.
Yes. So let's see what everybody has answered. Case number 3. So neutrophilic dermatosis, sweet syndrome gets the highest number. 21 people have answered, so we're giving that number 1. I don't know where myelogenous leukemia and sweet syndrome has come. Somebody maybe thought that the lymphocytes, the leukocytes, they are abnormal. Should we give them any marks?
I
No.
think
No.
there is, on one side, there is some sort of a ulceration of the epidermis, and with the combination of neutrophils and occasional eosinophils, I thought whether it could be drug-induced vasculitis.
Drug-induced vasculitis.
On one side, there is some sort of an ulceration of the epidermis you observe.
I think that may be just
Not this
sectioning
one.
artifact.
I think towards that extreme.
Let me go to lower power.
This.
Again, I think that is maybe just a cross-cut, man. The epidermis is ending here. And I think that may be just how this is a deep dermis, no? This is just a blood, this you can see the biopsy margin. So I'm not sure that is ulceration because that is actually the deep dermis. You don't see, that is the fat you're seeing there. So I think that is a deep dermis and you're seeing blood there. I don't think that is ulceration, personally.
Don't you think
Manoj,
it is necrosis, no? This one.
I don't think so, madam. I think this is just, this is too deep for necrosis. This is just fat. So this is just the biopsy margin, I feel. Manoj Singh, sir, what do you think?
It is connected to the epidermis also. So I thought it is necrosis.
I would not think so. I think this
It has got a specific appearance also with all the fat, subcutaneous fat and all. So I
would
interpreted that way.
The
Anyway,
artifactual.
it should be clinically correlated. I cannot say, but these are my findings.
Okay, so let's go back to the thing. So myelogenous leukemia, we're not giving any marks, right?
No.
Erythema nodosum leprosum, NHL, I'm not so sure. DLE, acantholytic AK, I don't know where that came from. Granulomatous vasculitis, again, no. Connective tissue paniclitis, granuloma faciale, I don't think so. Cutaneous tuberculosis, secondary syphilis, viral exanthem, again, it's too non-specific. Pyoderma gangrenosum is a neutrophilic dermatosis, and if you go by MAM's finding of an ulceration, then somebody may think of pyoderma gangrenosum. But the history,
I think history is given, no?
Yeah, history is given, so that's not a pyoderma gangrenosum, so we can't give that any marks. So yes, I don't think we're giving any of the others any marks. I'm submitting it as is. So only neutrophilic dermatosis sweet syndrome gets an answer. Okay.
Yeah.
So then moving on to the next case, case number 4 is a 40-year-old.
Yes, just one comment about what we were discussing. That's why I shut up in the middle. We actually are putting a lot of emphasis throughout dermatopathology. Eosinophils we associated with drug-induced. And I have a feeling that, maybe not we, but many of the younger people here are going to come up in the next 10 or 20 years with an analysis of eosinophils as an indicator to allergic reactions. And, we are using drugs as a catch basket. That, maybe drug. And the clinician looks, and obviously a lot of people are getting a lot of drugs. But, I have a feeling that, sometime in the next 10 or 20 years, we are going to come out with a lot many more allergic causes besides drugs. Because just a generalized kind of a viral infection causing an allergic reaction and whatever triggers. But we are putting at the moment, which is okay. That's as much as we know. We are putting a lot of stuff into drugs and finding a lot of results also. I'm just feeling that 10, 20 years down the line, we will find that allergic reactions are caused by very much more than drugs only. Sorry, that's all.
Well, if you believe all the patients, then every food item is caused by every food item can be a potential. Fine. So case number 4, Dr. Lavanya's turn, I guess.
Yes.
So this is a 40-year-old female with itchy erythematous maculopapular rash over trunk and proximal limbs of 10 days following episode of fever. So both the histories are pretty much similar, but the histologies are a bit different. Clinical DDs were morbilliform, drug eruption, viral exanthem, pityriasis rosea, secondary syphilis, and vasculitis. That was a wide range of clinical differentials. So let us see what the histology shows. This is obviously, bit of a cross-cut specimen. Dr. Lavanya, you want to comment?
Yes, sir. So the section shows skin with only skin, and the epidermis is unremarkable. And dermis shows lot of perivascular and interstitial infiltrate.
Yes. So epidermis, would you say is normal? What does your comment?
Epidermis shows spongiosis with occasional eosinophils lining along the basement membrane, and also some eosinophilic spongiosis I could make out.
Nandakumar sir, all yours. You have to take over.
Oh, this is my case.
Yes, sir. You can go through with Dr. Lavanya.
So I found one eosinophil sitting within the spongiotic epidermis at one focus, and a few eosinophils lining the basement membrane. And apart from that, in the dermis, there were perivascular lymphocytic infiltrate with prominent eosinophils in the interstitium also.
Yeah, I think there are other focus also where you can see good number of eosinophils.
Yes, sir.
Here, yeah.
Yeah. And there was no evidence of vasculitis. Endothelial swelling was there,
Yeah,
but
absolutely.
vasculitis
Wow.
changes were not there.
Yeah.
And solar elastosis can be seen.
Yes, yes. Actually, we had a problem in labeling the lesion to a distinct entity. What is your suggestion? What would you call this?
It is eosinophilic rich dermatitis. I thought of drug eruption or eosinophilic cellulitis.
I call it as eosinophilic dermatosis, and wanted the clinician to rule out by all possible tests causes of an eosinophilic dermatitis. We are nowadays recognizing more and more cases where the infiltrate is very rich in eosinophils. We have in fact, a spectrum of lesions where such eosinophil-rich infiltrates can be seen. Some with the flame figures, some without flame figures, some with the hematological findings of eosinophilia, increased absolute eosinophil count and things like that. But one thing which we have to keep in mind is that if it is an elderly patient who has got features of eosinophilic dermatitis, which is not responding to conventional treatment modalities, the patient has to be evaluated to rule out any underlying systemic cause. That is the purpose of keeping this slide. So again, discussion with the clinician is very important. Our patient had lesions on exposed areas. We first thought about an elderly gentleman. We first thought about photodermatitis or some connective tissue diseases. Eventually, he agreed. Some of the lesions were even psoriasiform. So eventually, he agreed to do the biopsy, and this was the histopathology. So instead of just giving a one-line diagnosis, a descriptive diagnosis with discussion with the clinician, counseling the patient regarding the importance of further investigations. That is the way this case has to be approached.
Sir, some cases we have seen where we have seen the sort of eosinophil collections in the eye lesions and some cutaneous lesions. IgE related, there may be increase in the IgE in the serum, I think. Sir.
Yes.
A newer diagnosis. Yeah.
Yes, agreed. We do see in some cases, the IgE may be in the thousands in some of these patients. I think what we can best do is do all possible investigations to rule out any underlying systemic cause. Do an ultrasound abdomen, perhaps do a bone marrow, A peripheral smear, of course, is a must. Why ultrasound abdomen, a solid organ malignancies, or even conditions such as ulcerative colitis and things like that can present with the eosinophilic dermatitis. It's a long list of conditions. We cannot possibly investigate patient that much, but at least the basic investigations has to be done.
So would you be happy if somebody calls this Wells or Wells spectrum, sir? Because that is what you're essentially proposing. Because though there's lack of flame figures, you're essentially proposing a similar.
Yes. But the problem is for the clinician how to proceed with the management. Sasi, if you are, getting a report like this, how will you proceed?
I agree with you, sir. I think this is a case of you've recognized. I think the important thing for the pathologist here is to recognize that this is not a purely skin disease. This is a systemically associated skin disease. Inform the clinician to investigate systemically and come to a conclusion rather than give a specific diagnosis on histopathology alone. I think that's important.
Yeah.
That we have seen recently one case where are some disseminated papular lesions. Biopsy showed neutrophils and plenty of eosinophils. And one dermatologist suggested, can it be a disseminated scabies with eosinophilic reaction? Can we also think such lesions, sir?
Definitely, if the clinical picture is suggestive, definitely. From very common conditions to serious conditions can show this picture. That is what I wanted to convey.
Scrapings of the skin may show the scabies parasite or something like that.
Absolutely.
Yeah. See, this is where I started off saying that, what is causing an allergic condition or a widespread allergic condition, we don't know.
We don't know.
Commenting on.
By coincidence, Dr. Manoj Singh started talking about the presence of eosinophils, and the next case, exactly, we are seeing this.
I was just talking about the fact of my own lack of knowledge. That, like, for example, what ma'am says, yes, scabies is definitely possible. Here, you don't see scabies. Right? So, point is, if there is widespread scabies and it has caused a widespread reaction, and this particular lesion, you are not seeing scabies, but you're seeing the reaction. That's what I said, that anything could be causing an allergic condition and you are seeing it kind of here. And actually, what Nanda said also, that this is a systemic associated allergic reaction. Yeah, sure, why not? But we are in this particular case, we are not very well advanced. So I think a clinician has to, kind of now start thinking that this is a very widespread allergic reaction which has caused this morphology in the skin. And now what the possible causes could be. Because here we can only give a link to so much. We can't go really.
That is very important. I think you're slightly underplaying the fact that we don't know. Actually, we know that this is a systemic. I think I would like to just emphasize that actually what we know is much more important than what we don't know. We know that this is a systemic association, and I think that the dermatopathologist role here is very important because we're pointing them towards a potentially major systemic illness.
Correct. We are contributing hugely to the management.
Yeah.
Sir, would any of you consider eosinophilic sweets, given that we discussed sweets earlier and it's in the same the history is similar?
Sweets, yeah.
Eosinophilic sweets?
Yeah, we are, I think we then reach the region of speculation. So I better to describe it and then ask the clinician to, kind of relook at the case. And, try a clinico-pathological correlation after a little bit further workup, so that we are then thinking about, the clinician then goes back that, okay, what could be causing an allergic condition in this patient? And, as Nand said, yes, a clinico-pathological correlation and a discussion between the dermatologist and the pathologist is most important in this kind of a case.
So, Nandakumar, just a doubt, who's giving you these excision specimens? The clinician.
I didn't hear what you said.
Who's giving you these excision specimens for skin lesions? I mean, they're quite huge.
The large biopsy. Yeah, this was in fact, I mean, one of my dermat colleagues only. We did a good biopsy. Yeah.
Yes. Okay. So next one is
Can you
pretty-
think of any chimeras?
In this,
No, for
no.
just discussion.
Not
No.
in this slide.
No, ma'am.
Not in this slide.
No.
Okay. So I'm going to the now I think we have to be a bit more liberal here, given that this is a descriptive case, remember?
Yeah.
So somebody has called it drug eruption. I think we should give them some marks. I mean, nobody is going to get full marks for anything because we don't know the exact answer.
Yeah,
So,
drug eruption gets 0.5.
yeah, drug eruption,
Yeah.
I think should get 0.5. Viral exanthem, should it get marks? This many eosinophils?
No. No.
No.
Viral exanthem out of question or 0.25? This many
Well,
eosinophils are unlikely to viral exanthem.
it's throughout the dermis.
Yes.
So, I mean, where is the virus? Like.
And there is no epidermal changes,
Yes.
nothing.
Yeah.
Okay.
Yeah.
Pityriasis rosea,
No.
urticarial. I'm not sure where the diagnosis comes from. I have to look through the database, but somebody's called it urticaria, but I don't think that's urticaria.
No, we cannot.
Secondary syphilis, I mean, that was in the clinical differential, but I don't think there's any features
No.
suggest that. But
No.
and eosinophilic folliculitis, it's not really a folliculitis. So even though they've identified the eosinophils, are we giving the marks for eosinophils? It's a pretty basic thing, so I'm not sure we should.
There is no folliculitis per se, but whether we should give some credit for identifying so many eosinophils.
I think the point one I think we can probably give. But no, I don't think so. Do you agree?
No. I think we will leave it.
Fixed drug eruption, acantholytic diskeratoma, granulomatous vasculitis, hypersensitivity reaction. Yes, I think should receive as
Yeah,
many
we can. We can give 0.5.
Yeah. PIP, I don't know where that came from. Church-Strauss syndrome. I mean, we haven't given any other history to suggest that. There are eosinophils.
0.25.
There's no vasculitis, though.
There is no vasculitis. Yeah. No, I think we shouldn't give any marks.
Yeah, that's
I think
diagnosis, right?
Sasi, I think we should. I mean, I feel we should definitely sort of give positive consideration to somebody who has gone so far and stopped. If you're speculating in this and this and this, then that's. I mean, I don't think that's justified in a case like this, because this is a very difficult case to analyze, in the sense that you describe it. And then there are, 20 or 40 or 50 possible directions you can go in. So I feel it's an important thing to know when to stop thinking and say, okay, let's now look at the clinical features again.
Yes. So to call it Church-Strauss syndrome is a bit too far-fetched, right?
Yeah, of course.
Yeah. Okay, fine. Okay, so we've done to 5 more cases to go. Next one is pretty easy. So maybe Nandakumar sir, I'll get I'll get Dr. Shika to do it, because it's easy actually. You could do it in 2 minutes.
Yes, sir.
45 male with an asymptomatic firm papular growth on the lateral aspect right index finger for 8 months. Nandakumar sir, I've given my own histories because you didn't give me the history, so this is okay. The clinical DDs were verruca vulgaris, periangle fibroma, and cutaneous horn. So, Dr. Shika, if you want to...
Yes.
Can you just rotate the slide, the image? This is actually a low power diagnosis, isn't it?
Yes. So, what I see here is it's an exophytic lesion, which shows marked compact orthokeratosis and marked acanthosis. And underneath the epidermis, I see the dermis, which is, I need to go a little bit higher, maybe. There is a lot of fibrosis, vertical streaking of collagen, and and few dilated vascular channels, and minimal inflammatory infiltrates.
Now you look at the history and give the clinico-pathological entity.
Yeah,
What
because
will you
the
call it?
lesion is located on the index finger. So
Yeah.
I'm thinking of digital fibrokeratoma, sir.
Keratoma. The DD1 but differential Sasi has put is viral what? Did we see any coilocytic change?
No, sir. There is some hypergranulosis, but I didn't.
That's all. That is all. That's all. It is
Yeah,
not a
I
viral
didn't
one.
find any. Yeah, I didn't find any coilocytic change, sir.
Yeah. So the most appropriate diagnosis is what you said, isn't it?
So what about periangle fibroma? Is it in the differential or the histology?
So that is usually associated with tuberous sclerosis.
Yes.
So there's no clinical history as such. I thought that clinically it is not suggesting that.
What about on the histology alone? Say I said this patient's got multiple lesions.
Perhaps he is hiding the fact that the patient has tuberous sclerosis. Who knows?
Yeah.
Is it possible? What do you think?
It can be possible, sir. But
How do you differentiate between those two, if they can be differentiated? Can they be differentiated?
the features are very similar, but that vertical streaking of collagen and dilated vessels, I think, favored fibrokeratoma.
Okay. Did you consider that, Dr. Nandakumar sir? Did you consider periangle fibroma or histologically?
Personally, I didn't.
And what do you? I mean, how would you?
Yeah, I think here the epidermal changes are far too striking.
Yeah.
To call it as fibrokeratoma rather than periangular fibroma.
I thought, I mean, the history is the clue, and normally you have periangle lesions there. This is not a periangle lesion. We didn't mention that. And I think looking at the literature, I think these are very close differentials, and that's why I asked it, because they can be a bit of overlap histologically. They can look very similar. I think here the inward, the lesion is much more, the textbook is described as in the periangle, the acral distal fibrokeratoma. There's a bit of inward turn reticulous sort of circumscribing the lesion a little bit. But I'm not sure if there are any other features that can help. Maybe Manoj Singh sir, what do you think? If that is in the differential, somebody put that as differential. Is this acral digital fibrokeratoma or periangle fibroma?
Yeah, I would stick to those areas, and for a person who's kind of seeing this slide and thinking about the possible directions the diagnosis can be, one thing I think which has come out very well is the fact that this is not a papillomavirus lesion,
Yes.
which would be a differential bit for the acanthosis and the cutaneous horn forming on top of it, because we are not seeing any changes suggestive of a papillomavirus etiology. Then we go further that what it could be, and definitely if you start
Periangle
thinking,
fibroma as the clinical differential, you see. So that's why I'm asking, because that's what the quiz people who answered the quiz would be looking at.
Yes, I think that's a good direction. Yeah.
Yeah, it could be considered as a DD. I mean, Dr. Shika.
Yes, sir.
Again, you have to look at the history again. Perhaps see a clinical image also before signing up the report either way.
Okay.
So interestingly, 17 people have called it Reguka Valgaris. I don't know why.
No, they get only 0. Right.
Yeah, acquired digital fibrokeratoma 14, which is very good. Cutaneous horn, again, that's a very non-specific diagnosis. Should not get any marks in my opinion, but
no marks.
And I don't think Conan tumor. Therefore, there you go. So somebody has called it a Conan tumor. Again, do we give them some marks? The clinical is not supportive though. I mean, I put that as a differential just to confuse them. But I said the single lesion, 45-year male. So it's not really, age also is against it. Slightly older individual with a lesion.
I don't think we can give marks for any of the other diagnoses.
Right. Okay.
Yeah.
So submit that. Excellent. We finished this quiz relatively quickly. So we've got 4 more cases to go. Case number 6, Dr. Lavanya, maybe this is also a very relatively easy case. 36-year-old female with multiple firm skin colored to erythematous papules and plaques over the face and upper back for 6 months. No sensory loss, nerve thickening, scaling, clinical DDs, tuberculoid Hansen's, lupus vulgaris, sarcoidosis, or granuloma annulari. Dr. Lavanya, are you there?
Yes, sir.
Yeah.
So I see a skin biopsy. The epidermis shows some invagination, and there are multiple nodular, perivascular, or periadnexal infiltrates seen in the dermis. Nodular infiltrates in the dermis.
Okay. So going higher, you want to comment on the epidermis. So there you go.
The epidermis appears thinned out, and you can see granulomas impinging on the epidermis. And these granulomas are naked, devoid of lymphocytic infiltrate, and they are seen around perivascular, periadnexal locations. Multiple discrete granulomas. Some are elongated. Some you can make out that the granulomas are elongated also, but majority are like appearing naked.
Do you want to comment on the dermoepidermal interface, Dr. Lavanya? What do you think of the interface here? Is it preserved? Is it?
It is the granulomas are impinging on. There is no Gren zone. The granulomas are impinging on the epidermis.
So you called it a granulomatous infiltrate anyway. Is this a lichenoid and granulomatous infiltrate, or is this just granulomas impinging on the epidermis? Because the epidermis is quite thinned out. It's almost looking like it's maybe ulcerating here. Almost, there are only 2 layers left. What do you think?
It looks like a lichenoid granulomatous infiltrate.
Would you say it's lichenoid here? Okay, let's we'll discuss that. Dr. Nandakumar sir may want to comment on that. And
can you just show the height power of this area? Yeah, that on the right hand side.
I'll just rotate the slide slightly, maybe.
Yeah. Seeing some multinucleate giant cells syndrome.
Yes.
And nicely closely packed epithelioid histiocytes without any lymphocytes here.
And necrobiosis.
Necrobiosis, I think.
I saw an area which I thought might be. Yeah, this. Where was he? Yeah.
Yes, I didn't notice that, but maybe there is. Could be. Necrobiosis or fibrinoid necrosis, do you make a distinction, sir, or do you not make a distinction?
No, I don't. No, I don't.
Okay. Fine. There may be some focus somewhere. I'm not sure. We'll go on. Okay. So, yeah, Dr. Lavanya, based on this, what were you thinking?
Oh, granulomatous inflammation. My first DD was sarcoid. Like I wanted to think in terms of leprosy, but since nerves were not involved, I kept it as a differential. I thought more of sarcoidosis. And I also found a nerve which was free of infiltrate. Yeah, this location.
Good.
But other granulomatous lesion also has to be ruled out. So my first differential is sarcoidosis. Second is tuberculoid leprosy.
The problem here is that, our dermatology colleague would want us to commit on whether it is sarcoidosis or it is leprosy. We cannot sign off the report as with these 2 differential. That is the problem.
But we cannot. I was not able to come to a conclusion.
Yeah, I think that is exactly the reason why this slide was kept. Sometimes it is the distinction between leprosy granuloma and sarcoidal granuloma is very, very subtle. How to differentiate the 2, all theoretical points apart, sometimes we find practical difficulties, but we have to commit on either way. The points which I depend upon is one you already said, whether the granuloma involves the nerve bundles, neurovascular nerve bundles are involved. That is a useful finding, but having said that, we should also keep in mind that there are sarcoidal granulomas which can involve nerve bundles also. So that is not an absolute no. If I think the composition of the granuloma is the clue. Composition and the discreteness of the granuloma. That is why I wanted Sasi to focus on those areas which show the discrete granulomas. You can see them in the discreteness of the granuloma, composed entirely of epithelioid cells, few multinuclear giant cells. I would call this a sarcoidosis based on these findings.
Sir, I had one case, same confusion we had. My husband is a dermatologist, so I was not very convinced that it is tuberculoid Hansen's. So what I did is, we did a reticulum stain. So sarcoidal thing will not have reticulin, will preserve reticulum, whereas others, the reticulum is destroyed. So that is one thing. So we have confirmed it is sarcoidosis, and the patient also had pulmonary lesions. And another case is, I saw one case in Yellow Rasham Medical College. There was a single lesion on the forehead. So I thought usually it should be tuberculoid Hansen's. So the granuloma was also looking like that. But exceptional thing is, there were a lot of foreign body giant cells. So I had a doubt. I sent it for fungal stain at the SWIMS. It is positive. So we published the case also as entomophthalmomycosis. The fungal elements were very well seen. It's just like this, these epithelioid granulomas, everything. But still I had a doubt. Why there are so many foreign body giant cells? I was not satisfied. So I wanted to rule out any other thing. So fungal stain was greatly positive, and we published this case as entomophthalmomycosis, which is very rare. So that also possibility we have to keep in mind. So we have to go for a reticulum stain and a fungal stain, sir. But basically, I thought it is a sarcoidosis, but these are the stains that are required, I think.
Excellent inputs, madam. I think I agree. We should not sign out sarcoidosis as a diagnosis of exclusion. And when Dr. Nandakumar sir said that clinician wants us, I am actually a bit more relaxed in my view on that. I think it is also important sometimes to admit our failures or not that we are not capable of differentiating them sometimes, and saying that you need to correlate clinically. Because I have a case of clearly well demarcated, granulomas like this, which was tuberculoid Hansen's, and patient had tuberculoid Hansen's and loss of sensation, everything else. And therefore, clinical is very important. On that note, Dr. Nandakumar sir, do you think the lichenoid granulomatous infiltrate is typical, or is it atypical for sarcoidosis? Because it is not usually in the differentials for a lichenoid and granulomatous infiltrate.
I think that also favors sarcoidosis, isn't it?
Yeah. But what do you normally see lichenoid infiltrates more in Hansen's? Because I see Hansen's a lot of granulomas involving the epidermis in Hansen's, particularly in the borderline
frank tuberculoid spectrum. The thing is that, Sasi, if nowadays if they want to start the patient on MDT, they want a documented diagnosis of Hansen's disease. We cannot give off a descriptive diagnosis. We can agree. We can discuss with them, ask them to do investigations to rule out sarcoidosis, etc., etc. But if they want to start the patient on MDT, they would want a documented evidence saying that the biopsy report saying that it is indeed Hansen's disease. That is the issue. So we will have to stick our neck out sometimes. Perhaps in some cases we may be going wrong. I fully agree. But situations like this we face in our day-to-day practice, isn't it?
I sit on the fence on this one, sir. Maybe I'm wrong. I favor sometimes. I put in a diagnosis, this is favored, but I never commit myself. I say that you have to do systemic screening because sarcoidosis is diagnosis of exclusion. That is in the definition of it. So unless you exclude an infection, how can you make a diagnosis of sarcoidosis on histology alone? So on the issue of sarcoidosis, I am not so fussed about sticking my neck out, to be honest.
See, even nowadays, even the patients are so well informed. I recently had that was not my case. I came to know about an issue. The patient had a report saying that the patient is having leprosy, and the patient was started on MDT. She developed Dapson syndrome, and the slide was subsequently reviewed in another center, and they said that there was no evidence of Hansen's disease. They made such a hue and cry. Such problems can occur.
Therefore, I'm saying, should we stick our neck out? Should we not rather give a descriptive diagnosis and say that these are the possibilities, please correlate? Because we cannot really make a definite diagnosis in a lot of cases.
Yes, yes, I agree with all the points discussed, but the clinician already have this differential diagnosis. Sasi, once you have for this patient, you will be already having the differential diagnosis of Hansen's disease and sarcoidosis. If the report also comes with the differential diagnosis of leprosy and Hansen's disease, it doesn't help anyone. That is
But
all.
you're favoring this. See, my
Correct.
way of approaching this is, you are saying that sarcoidosis favored. That is your diagnosis. But I'm not still sticking my neck out because I say sarcoidosis favored. But then in the comments, I say that sarcoidosis diagnosis of exclusion. These are still the possibilities. So please exclude them. So there you're building yourself
yes,
a fallback in case it goes wrong.
I agree. I think the days of one-line diagnosis are gone. We have to be careful about our interests also. So we have to protect our interests also. We can better give a descriptive diagnosis with a lot of CPC, advise additional investigations, including what Madam said. We have got a lot of investigations to look for evidence of sarcoidosis elsewhere on the body. I think that is the best approach. I agree. And maybe I'm slightly old-fashioned. When we started practicing pathology, looking at a lymph node with the caseating granulomatous lesion, we would say it is consistent with tuberculosis. We have stopped using that term now. We don't call it as caseating granulomatous lesion consistent with tuberculosis anymore. We just give it as a granulomatous lesion with necrosis, patient to be investigated further for tuberculosis. That is the terminology that I use now. So times have changed.
Manoj Singh sir, what do you think?
I think Dr. Lavanya has done a good job of pointing out the 2 or 3 features, naked granulomas, and which I have not seen on my phone. But if she's saying that nerve twigs, uninvolved nerve twigs are seen, because I had guided a thesis many years ago on exactly this, of granulomas and nerve involvement and all that, and we did find that a lot of these when you do the S100 in this case, you will see destroyed nerve twigs in the middle of the granulomas, and any chronic inflammation can incidentally involve nerve twigs. What we are looking for in Hansen's is the fact that the nerve twigs are primarily involved. And, I think those 2 features are important for, in pointing us to sarcoidosis. And the other thing is that what ma'am has pointed out very, very nicely was something which immediately came to my mind, the reticulin stain. And regarding that, I'd like to add a few points. Reticulin is a relatively simple stain. It's not, one of those complicated stains. We can't do it and all that. Yes, reticulin can be done easily. And sarcoidosis is a situation where granulomas occur, but they do not involve the reticulin. People have talked about, reticulin proliferation inside the granuloma and all. It's not a proliferation, it's preservation, relative preservation. And again, in that thesis, we had done the reticulin stain, and we also found the fact that, in all sorts of granulomas, tuberculoid leprosy, tuberculosis, fungal, this, that, and any inflammatory granuloma or a granuloma in which you can think of a cause, you will have reticulin destruction. So in those cases, in the reticulin, you will have punched out holes, which correspond with the granuloma. And in sarcoidosis, you will not have that. sarcoidosis, definitely in the reticulin stain, you can make out that this is the uninvolved dermis and this is the granulomatous dermis, in the sense that there will be less or more, which is why I said it's a relative preservation. So a reticulin stain is an easy way of kind of extending our thought process a little more. So I think this is I would say this is sarcoidosis. And as far as tuberculoid leprosy is concerned, I would not confuse the clinical scenario that it may be this. Of course, it may be this. And the one thing which we do routinely at AIIMS and all is to polarize the lesion. What ma'am had
Yes,
suggested about the
very,
ground.
very, very valid point. Very valid point. One can do the polarizer also.
I think I have seen some abnormal giant cells with satellite star-like inclusions in some of the foreign body giant cells. So I voted for sarcoidosis.
So sarcoidosis is what majority have called it. So we're giving it we're giving it 1 point. Tuberculoid leprosy, how much are we giving it? I mean, somebody, if they call it tuberculoid leprosy on this, how many points are giving?
No.
No?
If somebody else on this morphology call it BT or no, actually TT, you won't have such a exuberant granuloma. Somebody else call it
Where there are no lymphocytes, then how can you call it as leprosy? Leprosy there are no lymphocytes. They are purely naked granulomas. I wouldn't give credit for leprosy.
Okay. Even though they are curvilinear and all, you don't
No,
think...
no. That's what I said. Morphology of the granuloma is the composition of the granuloma is crucial.
Yeah.
I personally feel maybe 0.5 is deserved for people who was thinking about that spectrum. But I'm happy to go with the majority. Not even
These 11 people, have they suggested sarcoid at all?
I don't know. They may have chosen 50%. See,
No, I don't think so. I don't think, because after all, the biopsy was done for a particular purpose, to help the clinician distinguish between the 5 or 6 diagnoses. And here, I don't think BT is
okay. Not even 0.25. They've thought about the spectrum.
Any granulomatous inflammation in the skin will be BT. I mean, differential will be BT.
But it's curvilinear to some extent. No?
Curvilinear, I don't think makes all that much of a difference here. Ramam gives a lot of attention to the scanner view and saying that this may be. But then further you go that this is, naked granulomas. That these are granulomas which are actually, contiguous, impinging on each other. And of course, as Dr. Lavanya points out, that there are some nerve twigs which are actually not involved. In those nerve twigs, in fact, if you were seeing some inflammation coming in the nerve substance and all that, then yes, I think BT would be justified. But BT in this case, I think should be justifiable. I don't think it is justifiable here.
Nandakumar sir, 0 as well for you as well?
Yeah, perhaps from next session we will have 0.1 also.
Okay, so I don't think you will agree to we're agreeing to any of these anyway. So I think we'll give them all zeros. Okay, so the remaining ones are okay. Fine. So we've got 3 more cases to go through quickly. Let's see. The next case is 28-year-old male with asymptomatic hypopigmented patches over trunk and upper limbs for 2 years, slowly increasing in number. No sensory loss or scaling. Clinical DDs, post-inflammatory hypopigmentation, pityriasis alba, early Hansen's, hypopigment MF, morphia. So I thought this was a bit tricky on low power. So Dr. Shika, maybe you can comment on this. Obviously, 2 sections facing each other. We'll go through them. I think either of them is fine. So both of them show similar features. So you can maybe...
Some sections are not good.
Yeah, it's basically 2. Yeah.
Yes, sir. So on scanner view, I can see epidermis and dermis with minimal subcutis. There is not much inflammation in the dermis, and I would like to go a little bit higher.
Let's see the other section. I think that is better. Okay, right. Okay.
This is better. Yes, yes.
The epidermis shows basket weave orthokeratosis and mild uneven psoriasiform acanthosis. There are focal areas in the epidermis where I can see minimal sponge uses and some. Actually, I was confused here if it is mild epidermotropism, which is there focally in both the sections. Focally, I found some lymphocytes were going up in the epidermis, and I thought minimal epidermotropism was there.
Okay. Did you think that was enough to
But
call it
I didn't find.
mycosis fungoides, which the
No, sir, I
clinician
didn't.
was asking?
It's a long-standing lesion since 2 years on the thigh. That is a non-sun exposed area, but forearm is also involved. And I didn't find any interface changes. I was thinking on the lines of PLC also, but I didn't find interface changes.
What
And
about here, Dr. Shikha?
Is there?
yes, sir.
Isn't this all interface change? All this is interface. I think what you are seeing is predominantly interface change, to be honest.
Okay.
All this is the interface vacuolar. So when I'm saying interface change, we mean interface vacuolar change, right? So you can see this
Yeah.
vacuolation going all along the basement membrane. It's not,
Yes.
it's more or less confluent, but there are patches in between where there's nothing there, for example, here. But you can see multiple foci of this interface dermatitis, vacuolar interface dermatitis.
Okay.
You can see that in multiple foci, and sometimes I mean, you can, there's an argument, are these nuclear vacuoles of in atypical lymphocytes in MF, or if it is the case of MS, then you may be confused. Is this a true vacuolar interface where the basement membrane has got vacuolar interface change, or is this vacuolation within the lymphocytes itself? But
Okay.
still, there is definite, in my opinion, there is definite interface
Okay.
change, vacuolar interface change. Dr. Nandakumar, sir, maybe you can comment.
Yes, I think we have to give importance to the alignment of the mononuclear cells close to the dermoepidermal junction.
Okay.
You can see at many focus we are seeing those mononuclear cells very close to the dermoepidermal junction with migration of few of these mononuclear cells into the epidermis.
Yes.
But if you ask me, are we able to appreciate any significant cellular atypia or nuclear atypia? My answer would be I am not. I am not. But the architecture of the lesion is very suggestive of a cutaneous T-cell lymphoma. In such a scenario, whether ISC would be helpful is doubtful.
Yes.
It may not really contribute. We may have to do clonal studies. That is one way of going forward with the case. If we do not have facility for that, what I do in my reports is that I will ask the patient to be kept under strict follow-up, look at the evolution of the lesion, and do serial biopsies. We may have to take even 3-4 biopsies before histology-wise or immunohistochemistry-wise we can confidently sign it off as mycosis fungoides. And my feeling, of course, I'm open to suggestions from Sasi, is that cutaneous T-cell lymphoma is not we do not need an emergency diagnosis. The patient can be kept under follow-up, and the pathologist should be given the option of looking at multiple biopsies. But this is suspicious, definitely suspicious. That suspicion should be made clear in our report also, and communicated to the clinician also. That the architecture of the infiltrate is very, very suggestive of an evolving CTCL.
So you're not sticking your neck out, sir?
No, in this case, no. No, I won't.
Okay.
I won't.
So, Dr. Shikha, what did you think this was then?
So I
You-
thought that minimal epidermotropism was there, but there was no atypia in the lymphocytes. So I was thinking of PLC versus MF. But of course, for MF, clinical correlation and follow-up is required.
Here to some extent, clinical information will help. But in PLC, the interface change is very florid. We see a lot of
Yes,
pigment
sir.
incontinence and all. That is
Yes.
not seen here.
There
And
is
we
a
do
bit,
see,
there is a bit of incontinence here.
yes. Yes.
But PLC should have parakeratosis. Confluent parakeratosis and spongiosis are hallmarks of PLC. Generally, you should see at least some spongiosis and also parakeratosis, which is absent here.
Yes, sir.
This focus is I think, most important part of the section. The alignment of the mononuclear cells along the dermoepidermal junction. That should alert us about a possible CTCL.
So what is your diagnosis, sir, in these cases? How do you sign this out?
I sign it off as a descriptive diagnosis. I tell that there are these findings I mentioned, that the patient has to be kept under strict follow-up to rule out possibility of CTCL with repeat biopsy. And I will even discuss with them whether if the patient is developing any new lesions, that lesion has to be biopsied. And I also make a request that if the patient is applying corticosteroids or taking corticosteroids, that has to be stopped for 2 to 3 weeks prior to the biopsy. These points I make it clear. They immediately ask, why can't you do IHC? I will have to to explaining to a pure clinician that IHC is not a answer to all the things. It takes a bit of an effort. So,
I mean, going back to clonality, there have been clonal, T lymphocytes found even in vitiligo, psoriasis, etc. So I'm not sure clonality can help either. It's based on, it's purely morphologically and clinically based diagnosis.
Correct.
And I agree with you that we can delay the diagnosis.
Yeah, I'm sorry. Please complete what you're saying.
Go on.
No, our appreciation of significant cytological atypia, that is a huge clue. It comes with experience, when to call something as an atypical cell, or whether this here the nucleus is not atypical. I wouldn't call it as atypical.
So we'll have a case of proper Barndor mycos fungoides maybe in the coming session, and that will make it clearer.
Yeah.
But
Yes.
make a diagnosis of mycos fungoides, the pathologist should be absolutely sure, because it's a life-changing diagnosis. Your diagnosis cancer.
Even on the lower hand side, around 7 o'clock position, you can see the mononuclear cells slow migrating into the epidermis. Yeah, here. That is suspicious,
Yes. Manoj Singh, sir, do you have a different approach to signing out these reports?
I think Dr. Shikha and Nand have done a great job of describing and analyzing this case. I totally agree with them. A couple of things I'd like to ask, almost peripheral things. This in the description, this started off as a pigmentary disorder, and the clinical suspicions, and here we can clearly see, which can be potentiated if necessary. Maybe as a teaching tool, whoever's case this is, we can do a couple of stains for melanin. But very clearly, you're seeing that in these 2 or 3 small areas where there is actually inflammation, you saw in the low power, and in the peripheral areas where the skin is relatively less involved. In those areas, actually, the pigment is nice and normal. And in this area, there is, in the basal layer, pigment is less, possibly caused by this this reaction or this infiltration. And we'll perhaps at a later stage talk about a few of the common stains which can be used for demonstrating melanin in pigmentary disorders, not HMB45 and so on. Those are going to HC. Even simple our plain histochemical stains can be used, but in fact in this HND you can make out that the pigment is normal in the basal layer in the uninvolved areas, and it is definitely compromised in the inflamed or whatever involved areas. That I think is an observation which should happen at the back of your mind, that the description was hypopigmented. And there is normal and there is hypo. So I think That needs to sort of just be observed a little bit.
Okay. Anybody has got any other comments? Have we moved to the diagnosis part, answers part?
There's atrophy of
Okay.
the next and lot of fibrosis. Why can't we think of scleroderma?
That's what I put that as a clinical differential, ma'am. I think that's good
That's right.
quarter. I think the reason why I put that as differential is because for the exact reason, because there's loss of appendages. But then loss of appendages can be seen in any chronic, even, whether you call it parasoriasis, whether you call it hypopigmented MF, PMF, whatever you call it, any long-standing thing can lead to a bit of loss of appendage. Even vitiligo can have loss of appendages, but also this is a biopsy from the trunk, I think. And when you biopsy the trunk, often the specimen, the collagen modules look thickened and adnexia is sparse. So that can give you an illusion of morphia. That's why it happened in the clinical differential to just confuse people. I was thinking about what diagnosis to put, but I think that's a good thing to consider, certainly.
What about nevus anemicus? I don't know about the clinical aspect.
Inflammation to this extent definitely won't be there, ma'am. Nevus anemicus. This is Kiran interface dermatitis, right? So I don't think that. I didn't consider that certainly. Okay, so are we giving any marks for hypopigmented mycosis fungoides? Should they be committing on hypopigmented mycosis fungoides? Now, I'll tell you what I thought they should be committing on, and none of them have commented on that. I've put in a diagnosis called pre-mycosis fungoides. That is in the differential. That is in the list that can choose from. And nobody has chosen that. So I would have expected 1 mark, 100% marks for pre-mycosis fungoides, which I put in as a one of the drop-down list. Is parasoriasis, stroke pre-mycosis fungoides was in the diagnosis database. So they could have chosen that if they wanted to. It's not that they didn't have any options. So, but this is what majority have chosen, hypopigmented mycosis fungoides. So what do the panel think? Should they have committed on that?
Well, as a direction, I think it is good. But I agree with you that, to label this mycosis fungoides means this goes to an oncologist. So
Correct.
I would hesitate to give such a strong positive opinion. Unless, as Nandat said, you do some studies, immunohistochemistry, clonal studies, this, that, and the other. So, I think that's a good observation you have made, Sasi, that, committing to mycosis fungoides at this stage, I think is fallacious. Definitely, as Dr. Chikha has done, they've gone along the line, but to end up in mycosis fungoides and such evidence, I think, is not warranted. So
Yeah.
I think what Sasi is saying, that this is highly suspicious and indicative. Yeah, I think that is true.
If we have a choice like pre-mycotic, I mean,
Yes.
that should be the diagnosis. I agree.
I'm sure there is. Let me just look it up just to be on the safe side, because I did type it specifically myself. So when they type in mycosis, they should get a differential of pre-mycosis fungoides as well.
Yeah.
Let me just, or maybe it said mycosis. Let me just see.
Here,
The last one.
Yes, pre-mycosis fungoides parasoriasis. It is there. So
Yeah.
agree that
Like
since it's
myelodysplastic syndromes, you mean? They are all pre-malignant conditions.
no, but
I think, Sasi, it is a Pandora's box. We are going to discuss about parasoriasis and pre-mycotic fungoids. The
I
discussion.
the spectrum because
I think we should have a couple of sessions on those.
Yeah.
Those are important areas to discuss.
And Whedon has also mentioned a term, that chronic superficial dermatitis. That's again a terminology that can be used. Chronic superficial dermatitis, patient to be kept under follow-up and rapid biopsy if needed.
Well, there in that, I think you are saying that this is chronic superficial dermatitis, meaning it is an itis, and you are not saying that it could be mycosis, pre-mycosis, suspicious, and all that.
Agree.
Follow-up to the patient is advised, and I don't know how you treat the hypopigmented lesions as a dermatologist. because patient needs some sort of a confidence, you know.
No, ma'am, that cannot be treated. These are difficult cases. The patients are often counseled, and generally, if they have any symptoms of itching, that can be managed. We normally give phototherapy to reduce the amount of inflammation. You can give them topical steroids for a bit. Sometimes methotrexate can be given if it's progressive cases. But yeah, generally, it's more or less counseling and asking them to review. Unlike vitiligo, this is not really responsive to treatment. Vitiligo is extremely responsible, even though it's much more, depigmented. This is rarely responsive. Do you agree, sir, Nandakumar, sir?
Yes, I agree. I agree. Anyway, the rest of the answer, none of the answers requires any credit. Whether
Yeah.
the only question is whether we give any credit for the first answer. I think from the discussions that we had, I think we cannot give any credit, isn't it?
Yes, we
Well,
cannot.
yes, I think because this is primarily a dermatopathology forum
Yes.
and not a general pathology forum. You know, a general pathologist, if they say, okay, this is mycosis fungoides, they say, okay. But a dermatopathologist needs to think it over a little bit. I thought, somewhere around the line, pre-mycosis was also one of the possibilities. I don't know whether somebody called it that or not.
Nobody has called
No,
it
no,
pre-mycosis.
nobody has.
Nobody has called
Nobody
it, right?
has.
So I would just say that this is, as far as the analysis of the features is concerned, I should not end up as mycosis fungoides,
Yeah.
because that means the patient goes to oncology or oncology treatment.
Yes.
That I think at this stage is not correct,
Yes.
because I'm perfectly happy if this patient these lesions regress in 6 months under close follow-up. I think that happens.
Shall we give for people who have considered hypopigmented mycosis fungoides rather than, and somebody who's called it pityriasis retinoides chronica or anything else, maybe 0.25 is warranted, I think. My personal feeling is that, because they've gone into thinking about it. The rest of them haven't even thought about it.
Yeah, I also agree
Yeah,
that we can give 0.25.
Yeah, because it helps
yeah.
differentiate people who have scored, at least some way.
Yes, correct.
Okay, fine.
So pityriasis lichenoides will not have mark?
No, not really, because as I said, it has to have much more marks. Spongiosis and parakeratosis, confluent parakeratosis and spongiosis are hallmarks. You can't really call it PLC based on that.
Okay. Focal spongiosis and
No, that's not really significant in my opinion. Nandakumar sir, maybe
Yeah,
your
here actually that is the most important
Hello,
point.
no,
There
I
is
cannot bother you.
no appreciable spongiosis, but there is migration of few
What's all
mononucleus.
the temperature was
Exactly
3
the
degrees.
point. We are not seeing any
okay.
spongiosis.
Okay, sir.
I don't know whose turn it is. Dr.
It's my
Lavanya?
turn. Yeah.
Yeah, you want to take it?
Lavanya.
So I can see a skin biopsy with a markedly thinned out epidermis. And I can see a lichenoid infiltrate in the dermis with prominent pigment incontinence.
And also you can comment on this as well, even on no bar.
Clefting, some basal clefting can be noted.
Yes, a max dose of space, if you can call it. Yeah, that's
Yeah.
the low bar, isn't it? And anything about the infiltrate you want to comment on? How deep it is, etc. Does it help? If it helps.
It is a superficial dermal infiltrate. And it is focally seen extending along the hair follicle up to the mid-dermal level.
Absolutely. Okay. So I think, I think we quickly finish this case. You've described it very well. I think even on low power, it's a lichenoid infiltrate. And you want to comment on these things here?
There are apoptotic keratinocytes and
Yes.
basal vacuolar alteration.
Yes.
The apoptotic keratinocytes are present at the basal level and some are at the mid epidermal levels, little above also. So I
Any
thought
other
of actinic lichen keratosis in this.
lichenoid keratosis?
No.
Actinic
No.
lichen planus.
Actinic lichen planus, you thought about it.
Planus,
Okay.
not.
Yeah.
Now, when you say actinic lichen planus, that is obviously based on the clinical. Are there any histological features you made a diagnosis on?
Some solar elastosis in the periphery, I thought, and apoptotic keratinocytes at a little higher level.
Okay. Now, why is solar analysis important in actinic lichen planus? Do you think that is an important differentiating feature?
Solar damage can lead to this.
Is that one of the ecological theories that solar damage causes actinic lichen planus?
No, sir. That's,
I think actinic lichen planus is primarily made based on the fact that it's on photo-exposed areas. And
yes.
in the West, if you look at the Western literature, people on photo-damaged skin type 1 and 2 skin has solar elastosis. So because of that, this is my opinion, of course, and other people can feel free to object. Because of that, they've actually mentioned solar elastosis as one of the primary features of actinic lichen planus, whereas in Indian skin, young people where we see actinic lichen planus on photo-exposed areas, you can call it actinic lichen planus, but you don't see photo damage necessarily.
Okay.
What do you think, sir? Manoj Singh, sir, what do you think?
I agree with Sasi. I think, adding the actinic part, I think is not correct. This is lichen planus full stop because of a simple reason. In my skin at my age, if I develop lichen planus on the forehead, there will be actinic damage. When you're saying actinic, you're saying that, maybe there is some linkage between the actinic and the lichen planus. You're not describing two different lesions. Better not to do that. Call it a lichenoid lesion, lichen planus or whatever. The other important thing here, of course, is as Dr. Lavanya had nicely pointed out, that it's extending onto the follicle also. At least half or three-quarters of some of the follicles are involved. Now, that is not actinic, that is more than actinic. So, I think putting in actinic itself is, at this moment, not justified. But I think this is a beautiful lichen planus, very extensive lichen planus. I would stick to that.
For sake of academic, discussion, the clinician, the lesions being distributed on sun-exposed areas and all, the clinician would definitely like to differentiate between a cutaneous lupus erythematosus and lichen planus. So I think that is the thing that we should concentrate on. There are no features to suggest discoid lupus erythematosus in this slide. This is lichen planus per se. Just for completion's sake, I'm mentioning this.
Okay, and the differentiating features that you would use to exclude DLE, apart from the basement membrane thickening, there is epidermal atrophy, follicular involvement. So people who are learning, they are seeing epidermal atrophy, follicular involvement. So what, in your opinion, is excluding the diagnosis of cutaneous lupus in this case?
We can do a Alcyon blue stain to exclude presence of mucin. And here the deeper dermis is spared. There is no periadinaxal infiltrate also. These two can be helpful in differentiating discoid lupus erythematosus from lichen planus in doubtful cases. And a PA is to look at the basement membrane.
On the H&E alone, sir, can you completely, if the history is different, and somebody said, is this the clinical is that of cutaneous lupus?
Lupus, yeah. But here I think the histology is only that of lichen planus. The points against it being a discoid lupus erythematosus is that there is no deeper component for the infiltrate. The adnexal structures are completely spared. And except for that, it only extends up to the middle level of the follicle. The deeper area is completely spared. So and there is no obvious mucin deposition. And the atrophic epidermis can occur in both DLA as well as in the lichen planus. And we will do a PA stain to see whether the basement membrane is thickened or not. Here, I would commit on a diagnosis of lichen planus if I am asked to.
Yeah.
So how would you then, that's very excellent, sir. I think juniors would to take note of all these points. Would you histologically or clinically consider this in the same spectrum as lichen planus pigmentosus and ashy dermatosis? So can the histology resemble, if this is clinically lichen planus pigmentosus or ashy dermatosis, would the histology be compatible? Have you seen this dense infiltrates even lichen planus pigmentosus?
Lichen planus pigmentosus, to me, the infiltrate would be less dense.
Much less,
Less
much
dense.
less,
Much less. Much less.
much less.
Ashy dermatosis, again, the infiltrate is much less. And whatever infiltrate along with the pigment-laden macrophages are present would be around blood vessels and blood vessels in the upper dermis. That is my experience. This much of interface change will not be seen in erythema, dyschromicum persistens.
Yeah, I thought the same, sir, until recently. Just about a month ago, I saw a case of clinically typical lichen planus pigmentosus, which had such a very band-like infiltrate, actually. And that is why I'm asking. Normally, you don't see. I agree that out of
Normally we don't. Normally we don't.
I've never seen it, but recently I saw a case and I was quite surprised myself. So that's what I thought. I'd just add that in. So, Dr. Lavanya, did you have any doubts about this case, or do you have any thoughts?
No, sir, I thought of lichen planus only.
Lichen planus.
And since it was at the exposed site and some evidence of, I thought of actinic.
Okay, so people have called it actinic lichen planus because that's what the clinician asked for and that's what he said. So I think we'll probably give that full marks. Do you agree, everybody?
Yes.
Yeah. Yeah.
Okay. PLE, unfortunately,
No.
Now, lichen planus pigmentosis, we didn't say there was any pigment, so I'm not sure. Did we say there's pigment? We said itchy pigmented papular rash. I mean, papular rash, I don't think so. Should we give
But they have recognized it as lichen planus.
Okay. So how far do we go? 0.75?
No, 0.5.
0.5. Dr. Nandakumar, sorry, Dr. Manoj Singh, sir, you agree?
I agree.
Okay. Ashy dermatosis, again, too florid for that. If
No.
No marks.
Both are in the same spectrum. So if you're giving this, why not this? Because ashy dermatosis is considered synonymous with lichen planus pigmentosus nowadays.
Maybe 0.25 for ashy dermatosis.
I'd just like to add one thing here. No, Nand, I think this should be 0 for ashy dermatosis. I'll tell you why. When I joined pathology, from that time onwards, Professor Bhutani, our chief of dermatology, he had been talking about ashy dermatosis, lichen planus pigmentosis, whatever. I like to think of lichen planus pigmentosis. Possibly either it's a different condition, I don't know. Whether it's a mild lichen planus which has kind of healed and is now presenting with the pigment incontinence to whatever extent, I would like to keep it in that area somewhere, right? So then if it is that, then to say that this is lichen planus pigmentosis in a very acute phase, that is lichen planus. So why involve those other things? Lichen planus pigmentosis or ashy dermatosis are basically pigment incontinence. And if you go carefully into the history, you may get a history that yes, at some stage this was lichen planus-like lesions, which have now ended up like this. Or maybe some lichen planus end up with hyperpigmentation, and some end up with healing and upper dermal fibrosis. That's a different issue. But I would, say that morphologically, we look at lichen planus pigmentosis as mainly, an end stage of lichen planus. Let me put it like this: the epidermal atrophy may be there, the pigment incontinence is there of varying extents, maybe upper dermal fibrosis is there. You say okay, and then you look at the patient very carefully. You may see some acute lesions, and most of the lesions actually are LPP like. So Bhutani used to differentiate between LPP and ashy dermatosis, have his own descriptions for whatever. But I would say that those are, kind of end stage lesions. There's no reason why a skin would end up with extensive pigment incontinence with melanophages and all that without any background lesion. That doesn't happen. Something has to have happened.
So do you use the term ashy dermatosis, sir, for post-inflammatory lichenoid hyperpigmentation? Post-inflammatory
That group, yes.
lichenoid.
I think it is that.
So then so you're saying that ashy dermatosis is essentially post-inflammatory lichenoid hyperpigmentation.
Yes.
And what about erythema, dyschromium persistens?
All of these things are possibly the end stage of lichen planus. Now, lichen planus
Then
in healing.
what about lichen planus pigmentosus then? Where would you consider lichen planus
I
pigmentosus
think
in
all
that
of these are
spectrum?
the same, yeah. I mean, why differentiate
Ah.
clinically between? I mean, yes, I do think that clinically you may be able to differentiate ashidermatosis, erythema dischromicum perstans, LPP, and all that. That clinically you may. Why should you? I mean, in the sense that a person has extensive lichen planus and it has healed. In some areas, it has healed. In some patients, it has healed totally, with leaving maybe in scars. In some patient, it is healed into ashidermatosis. In some patients, it is healed with something looking like lichen planus pigmentosis. My thing is that when you are differentiating these one, two, three, four conditions clinically, then you are saying that maybe their etiology is also different. I would say that these are all things which have which was lichen planus at one stage, and they have ended up in some slightly
So
different
just a slight
morphology.
sort of comment side. All these were not lichen planus previously. So actually, in my clinical experience, all these entities are macular lesions on patches rather than papules. So post-inflammatory hyperpigmentation in lichen planus is basically small, guttate small, very small macules, as in lichen planus, distributed discretely. Whilst ashidermatosis, erythema dischromicum perstans, or lichen planus pigmentosus, whatever you want to call them, I don't use these terms individually nowadays. I merge them all into lichen planus pigmentosus. I don't use them as separate entities. And in my opinion, they are all macular lichen planus. They are not the traditional lichen planus. This is macular lichen planus with atrophy. You don't see papules clinically, nor histologically do you see hyperkeratosis. You see epidermal atrophy. Depending on the stage in which you biopsy them, the extent of the inflammatory infiltrate may vary. And if you biopsy them in the post-inflammatory stage, you only see hyperpigmentation with pigment incontinence. If you biopsy them in the early stage, you see a dense, interface dermatitis, or relatively dense, not as much as in lichen planus. So, and that's the reason I put in this question. In my opinion, if you're giving a mark to lichen planus pigmentosus, the same mark should be given to ashidermatosis, because I don't consider them as distinct entities. I club them into one entity, as you've just said. Whether you call it erythema dischromicum perstans, ashidermatosis, these are all macular variants of lichen planus, in my opinion. And if you are if you're giving any marks to lichen planus pigmentosus, whether somebody calls it erythema dischromicum perstans or ashidermatosis, should be given the equal marks, is my suggestion.
I called something as EDP when the vacuolar degeneration is very focal, infiltrate is very less, and that too we do not find this kind of a band-like infiltrate. But from a prominent pigment incontinence will be there. The medullophages and whatever little lymphocytes are there will be oriented around blood vessels. That is when I give a diagnosis of erythema dischromicum perstans.
But does that not all depend on the stage of biopsy, sir? See, whether if you biopsy...
I fully agree. I wanted to make that comment. The statement that you made, the timing of the biopsy may be crucial. But, if we want to call something as EDP, these are the points which I would expect to be seen. In that way, I wouldn't give any credit for ashidermatosis in this particular slide.
Okay.
Can it be drug-induced lichenoid dermatitis?
Yes, sir. Yes, madam. All these would be in the differentials. Drug-induced lichenoid dermatitis. Somebody has called it that. I don't think anybody has called it that. Somebody has called it fixed drug eruption, but the clinical is not in favor of fixed drug eruption. So the question still is ashidermatosis. I personally feel that LPP and ashidermatosis should be given equal marks if you're giving any marks to them. So
No.
We will leave it to the third umpire, Dr. Manoj
I
Singh.
comment here, please. I was very, very, very interested in the opinions of Sasi and Nandakumar. And here I would like to say, after a long time, that this is one place where I am better than you guys, because I don't know clinical dermatology at all. So I don't get confused by all these issues. I am a pure pathologist, so I look at things slightly differently. And I would clearly like to differentiate that this is an acute lichen planus, what ma'am suggested about drug induced and all. We have no evidence for that. So this is basically an acute lichen planus. and with some follicular involvement. This is not DLE, and LPP or ashy dermatosis in an acute phase is actually lichen planus. So why involve those at all? Definitely, this is a lichen planus which has been going on for some months. There would be pigment incontinence. There is basement membrane degeneration, so the pigment has fallen down. So to implicate, and in this particular area, I think putting in the clinical sort of pattern is, I think, going a little bit too much, because this patient will be treated for lichen planus acute, right? So, why
It's a
suggest the
pigmented
other things?
papular rash. So it's a papular rash. So given that, maybe no mark should be given to either lichen planus.
Even LPP. LPP. Correct.
Yes, I think so.
Yeah?
I think so.
Correct.
Fine. No, my only question is, if you're giving marks to that, this has to be given.
No.
Yes, that's a valid point.
Right.
That's a valid point.
Excellent. Okay. So chronic acne dermatitis, I'm not sure we're not giving any marks to that.
Students should, one important point Dr. Sasi mentioned was regarding the timing of the biopsy. Students should remember that in the interpretation of the slide. Yeah.
I think these have been excellent discussions. These are ordinary cases, but then, these are very important discussions to have because these are all very clinically relevant discussions. And for people who are taking biopsies, it's very important to understand that we are not thinking of, we are thinking on multidimensionally. As pathologists, when we're reporting this, it's not one dimension we're thinking about. And this is why it's important to get all the opinions. You have a pure pathologist, you have two dermatopathologists. So I think it's fascinating having these discussions, and these are very important learning points. I've learned a lot. I don't know about the students today. I'm learning a lot. So this is the last case. I think equal number of cases have been answered with Dr. Shika and Dr. Lavanya. So you can, whoever wants to volunteer.
I'll go with the case, sir.
Okay, go ahead, please.
Yeah, so I can see.
Sorry, just a second. Let me go to the history. I forgot to mention that. The 34-year-old male with itchy erythematous scaly plaques or extensive limbs for 4 months. Lesions show partial improvement with topical steroids. Clinical DD, psoriasis, eczema, seborrheic dermatitis, and pityriasis rubra pilaris. Okay, please go ahead.
Yeah, section shows skin with the showing epidermis and the dermis. On this scanner view, I can see the epidermis showing uneven psoriasiform acanthosis, and there is a patchy lichenoid infiltrate in the upper dermis. Slight inflammation is there in the around the adnexal structures also.
You say lichenoid, Dr. Shika?
Patchy, sir. Not very much lichenoid, but patchy.
Okay.
On this part, if I see the epidermis, I can see compact orthokeratosis with parakeratosis. Underneath which I can see spongiosis with tiny spongiotic vesicles being formed with a lot of lymphocyte exocytosis.
Okay.
Scale crust is also there in this focus. And if I go to the dermis, I see moderate inflammation, inflammatory infiltrate, perivascular and interstitial infiltrate comprised predominantly of lymphocytes and many eosinophils.
Right, I think you're spot on a number of features. I think what you're mentioning is not focal lichenoid. You probably are referring to focal vacuolar interface change.
Yes.
Okay?
Okay, sir.
So there is some focal vacuolar interface change, but generally, as pathologists, we don't mention that unless we think that is clinically or histologically significant and would alter a diagnosis, because it will just confuse the clinician.
Yes.
What is the predominant pattern here, you think? Is it lichenoid, psoriasiform, eczematous?
I think it is spongiotic psoriasiform dermatitis with a lot of eosinophils.
Okay. If you're going for spongiotic and psoriasiform, which would you? Is it
I'm taking
spongiotic
in the
psoriasis or
line.
psoriasiform spongiosis?
Spongiotic psoriasiform, sir.
Spongiotic psoriasiform is your preferred this thing. Okay.
Yes, with a lot of eosinophils.
With a lot of eosinophils. Okay.
I mean, what do you expect? How do you expect the clinician to interpret that diagnosis?
It it uh, it is suggesting that chronic eczema, atopic dermatitis, or chronic eczema should be like kept in consideration. I mean, I'll write it like spongiotic psoriasiform dermatitis, suggestive of chronic eczema. I want to point it towards that.
The clinician has asked, is this psoriasis or not? So what is your
It's
answer?
not psoriasis. I'll mention the negative findings that there are no dilated vascular channels in the dermis, and I don't think I want to see the granular.
Suppose I am saying that this is psoriasis which has undergone eczematization.
Okay.
We have an
Yeah.
eczematized psoriasis also.
Yes.
Yes, sir.
How do you counter that?
I am not saying suprapapillary. The features which are favoring psoriasis, suprapapillary thinning.
Yeah, I agree. I agree on that point. There is no appreciable suprapapillary thinning. I agree.
The granular layer, though, is lost. But psoriasis will not show many eos. Okay, eczematized psoriasis.
Don't worry, just give your thoughts. I don't think there's a straight answer, so please go ahead.
Yeah.
There are no rights or wrong in this case. You just tell your opinion. Just wanted to.
I'll just mention the negative, the findings which do not favor psoriasis, and
see, but I'm just for argument's sake, I'm saying this.
Yes, sir.
There are, I think there are foci of parakeratotic neutrophilic abscess is there.
Yes, sir.
With regular acanthosis is seen in some areas.
Yes, sir.
Added on that, we are seeing foci of spongiosis with exocytosis. The infiltrate is mostly confined to the upper dermis, and there are eosinophils, as you rightly mentioned, which could be a point against psoriasis. I want opinion from Dr. Sasi and Manoj Singh whether they do see eosinophils in their cases of psoriasis.
Wow.
It is a point mentioned as against psoriasis. I want their opinion also. This case was I kept this case for discussion purpose. We face this problem in our day-to-day practice, isn't it?
What about this deep follicular involvement as well?
Yes, there is.
Absolutely. Yes.
Yes.
So Manoj Singh sir, please give your opinion on this.
In fact, I had briefly noticed this on the scanner view, and I think Sasi was deliberately avoiding this particular follicle, deep follicle, which is inflamed. But the fact is that there is all this going on in the upper dermis. What Dr. Sikha has nicely described, and this is actually not really psoriasiform. When you look at the scanner view, this is not psoriasiform infiltrate. Oh, sorry, acanthosis. This is actually irregular acanthosis because, psoriasiform is more regular. When you make out on one side, it's more, one side it is less, one side it is almost normal level. This is more apt to call it irregular acanthosis.
Yes.
And then the other thing, of course, whatever is happening in the upper dermis, there is definite, deep folliculitis. Dr. Shikha had mentioned actually that there is periappendageal inflammation. This is it. So, I think this is a beautiful counterpoint point to the earlier case. And then, of course, this particular follicle, that there is, this kind of plugging and follicular atrophy, that is the keratin extending all the way into the, depth of the follicle. So there is distinct follicular involvement also, apart from what is happening in the upper dermis. So with this distinct follicular involvement, I would like to start going towards, lupus erythematosus. That this is, some kind of a, whatever is happening there, lichenoid features of lupus erythematosus and so on. But with such follicular involvement, I would like to, go into that direction.
Would you think
rather than either.
the vascular interface change is enough and the vascular interface change is enough and the spongiosis, there's not much vascular interface change, so it's just very focal.
That's okay. That's fine. That's fine. That's what I said, that, we have been sort of talking about the upper dermis and, between psoriasis and eczematized psoriasis or eczema and this, that, and the other. But, with the deep dermal perifollicular involvement, I think, lupus is a good direction to think of also.
Just to counter that point, in lupus, generally my experience is that spongiosis is absent. It is more of, this is intra epithelial infiltrate. This is the infiltrate actually within the follicular epithelium rather than around it. In lupus, in my experience, and you may object to it, the infiltrate is around the follicle with interface change. Here, the infiltrate is within the follicle. So it suggests that the infiltrate is descending from the epidermis down. And this is the same with this follicle as well. You're seeing marked exocytosis of lymphocytes into the follicular epithelium with marked follicular spongiosis. So this is not the pattern I usually recognize as part of lupus. That is my opinion.
As Nand says very nicely, this is not really a case for diagnosis. This is a case for discussion.
Yes.
And I feel that this kind of follicular involvement, like here, you're actually not seeing so much of a follicular inflammation like you were seeing in the other follicle. There is definite, this keratin plugging and absence of the hair shaft, which means this has been going on in this follicle for some time. And in that one, it's actually, more active folliculitis. So here we are seeing, if you want, you can call it a combination of two different types of morphologies. But, to my mind, this, I would like to go along lupus erythematosus path, that there is folliculitis. There's nothing else to explain this folliculitis except, lupus erythematosus. This is not psoriasis. This is not lichen planus. This is not eczema. Those are upper dermal conditions. This is happening into the depth. So here I would be a little careful about, my thinking. So I think this is, more towards.
So this is your case. So you got the final judgment on this.
Yeah, I signed it off as subacute spongiotic dermatitis with focal psoriasiform hyperplasia. That is what I called it.
Right. Okay.
So I think it is psoriasiform dermatitis.
Yeah, this term I avoid nowadays, madam, because the clinician is confused with that statement. Psoriasiform dermatitis doesn't help him to manage the patient. He would like to know whether it is a dermatitis or it is psoriasis.
Yeah, I think psoriasiform dermatitis, for people who understand it, means that it's dermatitis, which is psoriasiform, which is the same as what you're saying, but people may not understand the terminology.
Yeah, exactly.
But then this folliculitis, where does that fit into?
But there is follicular psoriasis, sir. So follicular psoriasis is an existing entity. So maybe this is psoriasis or this is spongiosis affecting the hair follicle. Why can't that be? Because when
here also we can see the exocytosis of cells into the follicular epithelium.
And also, you're seeing a bit of eosinophils, so maybe there is a drug factor or something else that is causing this spongiotic psoriasiform reaction pattern. And there the hair follicles can be involved too. What is stopping them from getting involved?
Yeah, you are still to answer my doubt. Sasi and Dr. Manoj Singh, do you see eosinophils in cases of psoriasis? Straightforward psoriasis.
I have not seen them, sir, personally. They can be seen occasionally. Let me not, beat around the bush. Yes, occasionally they've seen, but they're not a usual feature. But I wouldn't use that to sway this thing. But it's not a feature that I've found in. If I see 100 cases, maybe one will have a few eosinophils. That's fine.
Can I go back to the clinical picture again?
We don't have a
clinical details.
History is 34-year-old male with erythematous scaly plaques or extensor limbs. So I am veering towards psoriasis there, but I'm not. I'm not really said anything else.
Let us see the answers.
Manoj Singh sir hasn't answered your question. So
Oh, I'm sorry. It's keeping quiet.
Manoj Singh sir, you still have to answer.
I have no answers.
You have no answers.
Why I specifically mentioned was that, Dr. Shiga also brought.
As I said in the last case, I personally feel that I am better off than you two guys, because my mind does not get confused by clinical aspects. I don't know clinical aspects, so I look at the pure histology
Well,
and what it correlates to. So I would, this folliculitis in both the follicles, actually, of different types of folliculitis, I would say that this is a feature which is an addition to what is happening in the upper dermis and the epidermis. So, and this is why I thought that this particular kind of change is, to my mind, leading me towards lupus erythematosus. And I would be very interested in seeing, deep cuts of this particular slide in order to work out what is happening in this particular follicle, the central follicle, in other regions. Here we are seeing only the tail part of the follicle, which is folliculitis. I would like to see what is happening in the upper part. And if it is happening, that kind of sort of follicular atrophy, keratin plugging going down into the deep follicle and all. Because even in this follicle, I don't think there is a hair shaft. It's that keratin plugging going down. So I would like to see several deep cuts of this biopsy in order to tell us what it, to perhaps help in our thinking a little bit.
Okay. I guess we'll have to put that to vote when the answers come. Before we finish, go to the answers, can I just quickly put in some audience questions that the Glodoma team has put in? The first question is how to differentiate fibrous papule from fibrokeratoma. I think we've already slightly discussed that, but we can maybe, Dr. Nandakumar sir, maybe you can quickly answer that.
Yeah, I think my thing is, the extent of the epidermal involvement, the architecture of the lesion, such an exophytic lesion with a marked tomb-shaped compact hyperkeratosis with bit of papillomatosis and irregular acanthosis point more towards fibrokeratoma rather than the other condition.
Yeah. And also the clinical as well, you don't see a fibrous papule. Somebody mentioned lichen viral infections show eosinophils focally, because fine, that's okay. Granzone should be absent in sweet syndromes, but it is present here. Somebody has commented.
No, that is not an absolute criteria to make a diagnosis.
Yes, absolutely. And somebody has said, can we call it psoriasis with pustules instead of pustular psoriasis? I guess that's semantic. Okay. Case 5, can this be lupus vulgaris since infiltrate is impeding in the epidermis? Somebody has said. That's yeah. So that's fine. I think that's the end of the question. So we go to the answers for this case, and then we'll maybe take a vote if there is a doubt on what. Let's see. So first one was psoriasis vulgaris, which 13 people have said it is. I'm not sure it's psoriasis vulgaris actually.
We cannot give any marks for that.
Yeah, but are we because there's no mark for anything? I mean, what are we giving a mark to? Have we decided on that?
I think it's subacute spongiortic dermatitis.
Yes.
I thought as well. Yes. So psoriasis vulgaris cannot be given
classical psoriasis. It is not.
It is
not. Obviously.
What about discoid or nummular eczema?
Yes.
Dermatitis. Yes.
I mean, maybe not one full mark, but at least half a mark or something. Because, this is exactly along the lines of what Nand is thinking. And what I would think also at this stage, I had just floated an idea of lupus because of the follicular involvement. But actually, sort of eczematous process, dermatitic process, chronic dermatitic process, that is what it is. So I think somebody who has, avoided psoriasis vulgaris I think, should be marked in this particular case.
I guess 1 mark, I think, is not unreasonable. I think if you're recording subacute,
Okay, I think it's fine.
Yeah.
I think even that is fine. Yeah.
PRP, unfortunately, no. Acus psoriasis, no.
No.
CBC, no. Psoriasiform dermatitis, are we giving that any marks, sir? Then if somebody is called...
Well, why call it psoriasiform? I mean, in this, either it is psoriasis or it is not psoriasis, or it is, approximately psoriasis. So, I mean, a chronic dermatitic process is not psoriasis.
Yeah.
So, why call it psoriasiform?
That is what I also try to tell.
What Nand has done in his diagnosis is actually a nice condensation of this particular case. And, at the end of the case, I have a few things to add, which,
I used to hear this term from my husband, who is a dermatologist. That's why I told you psoriasiform dermatitis. And usually in psoriasis, we don't find so many inflammatory cells in the upper dermis. But there is, in association with malignancies, there is one psoriasis, and same type of lesions can occur in the same person. Like we have seen in one case of chronic lymphocytic leukemia, where he developed both lichen planus-like lesions and psoriasis in the same biopsy. So that is a special name is given for that psoriasis.
Drug-induced and like in malignancy-associated conditions, you can have an overlap of features, madam. That is well known. Yes.
But anyway, because of so much of inflammation, I don't know. The dermatologist Sasi should say psoriasiform dermatitis, whether he agrees.
Probably we can give them some marks rather than because they've not diagnosed it as something else. What do you think, sir? Are we giving any or not?
Well, I mean, okay. I'm just questioning the thought process. A dermatitic process, it is. That is what it is.
That's what they've called it. With some
so give it 0.5 or something.
Okay with that, Nandakumar sir, 0.5?
0.5.
Okay. Goals, chronic spongiovale dermatitis, I thought we were giving that, but it's subacute. Again, I think 0.5 is better than for chronic.
0.5. Because we have 12 subacute spongiovale dermatitis is there.
That's right. Number 12 is very...
that's
that
was my diagnosis as well.
Yes.
PLE, unfortunately, because of molecular involvement, they probably thought about PLE, but then...
No.
It's too much inflammation, and there's not much infiltrate around the vessels, because in PLE you expect much more, perivascular infiltrate as well, rather than just confined to the superficial epidermis. Is that right, Dr. Nandakumar sir? Would you agree?
Yes. I think DLE should be given some weightage because of the deep follicular involvement. That there is acute lichenoid part of a DLE going on in the upper dermis, but definitely something is there. So if somebody has thought about lupus erythematosus, I think some weightage should be given.
PLE they thought about.
PLE.
Okay.
The history given is that the lesions are on the legs.
No, extensive surface of said. I didn't say whether it's legs or hands.
Okay.
So
0.25 perhaps.
0.25 probably is okay. I think because acute it's not, but then they've called it dermatitis. I don't know.
0.25. Yeah.
0.25. Seborrheic dermatitis, not really. I mean, histologically supported, but the clinical is extensive surface. I don't know where seborrheic dermatitis came from. Drug eruption, it's because eosinophils, somebody thought about it. I guess you can't exclude it.
Well, a drug eruption can look like anything on the earth here.
Yeah,
in this particular thing, you are looking for a little more. So I don't think so.
It's too non-specific.
Too non-specific.
Absolutely.
Right? Pityriasis rosea, again,
No.
Too extensive. Gutted psoriasis.
No.
The history is against it anyway. So PLC, I don't think so. I don't think we're giving any marks to the rest, right?
No.
Excellent. So that's all that submitted, and let's just see if. Oops. I think we'll have to do some back-end work for the results to be shown. I'll do that, and I'll post the things in the groups. So that was an excellent discussion, actually. I think, I don't know if the other panelists have things to comment on.
I mean, we had a very, very fruitful discussion. As Dr. Sasi said, we learn newer and newer things by discussion, even from
Absolutely.
people who are, we started doing dermatopathology. Even, they also contribute immensely to the learning process. Excellent discussion.
As you guys, both of you have been, developing along these lines with your clinical and pathological backgrounds. I was a little bit handicapped when I was at the institute because, I was a pure pathologist, even though I was, going to the derma OPD and seeing cases and all that. But I had the great facility of being able to ring up the what we had worked out the system that maybe a resident was filling out the form, but the name of a consultant who had seen the case was there. So I could ring up the consultant, ring up this, ask for the clinical details. So I didn't have any questions in my mind about the dermatopathological sort of correlation because I was able to discuss, and if necessary, we would discuss on a slide itself. But now, over the past 4 years, when I'm not at the institute anymore, I've evolved two or three formally because some of the clinicians are of course accessible on the phone, and I ring them up and I ask them, but a lot of them are not. So the formulas I'm using are RCF, which is review clinical features, CPC, which of course we know what CPC is, and in the end, I write, please discuss. Just two or three people have actually rung me back and asked me or discussed with me. But otherwise, I find these formally very useful because they straighten out my thinking also that, that the clinical features in this particular case need to be reevaluated. And, the clinico-pathological correlation, I'm happy to do it. But otherwise, I'm giving a description, please do it yourself. And then, clinical follow-up and if necessary, a repeat biopsy. Because in the repeat biopsy, this now I've seen in two or three cases that the dermatologist has actually followed my advice. They looked at the clinical features again. They've seen, whatever, if they've given some management treatment or whatever, they've seen that and the response of that. And then, if necessary, they've done a repeat biopsy where I got a beautiful description. So, the diagnosis was not all that difficult. So, this is something I have learned over the past 3 or 4 years that, always sound a note of caution and of looking at the case again. And I think, I mean, in when I was at the institute, we took that for granted because that was happening. In every case, we were able to do that. But here, I mean, I'm actually thinking of telling the clinician or something. So I am, a little. Anyway, I think this has been a great discussion. And, giving straightforward cases of psoriasis, lichen planus. I mean, anybody who sees a book or reads a book knows what they are all about. So here are the cases which actually cause difficulty clinically, pathologically, and in some cases even clinico-pathologically. So the most important thing in such cases is, of course, reevaluation of the case and a follow-up. Because many times then, our today what we are discussing, some months down the line, that will get straightened out because, you will see the evolution of these cases. And the last case, I think, whoever's case it is, some deep sections might, be a little informative also. Thank you.
Ramalakshmi madam, have you got, what do you think of this session? Do you have anything else to say?
Very nice discussion. I'm
we
very happy
enjoyed
to
your.
be one of the participants and
We
also
enjoyed your
contributing
presence.
some cases. And my interest is more in dermatopathology, so I'd like to continue to see your slides and participate. Very nice to have so many opinions, so much of discussion. It's really helpful for me also.
It was really nice having you in the panel, madam. Dr. Shika and Dr. Lavanya, do you want to add something? Did you like what did you feel? Was it too intimidating? How should we modify our future sessions? Too extensive?
No,
Very
sir, it is.
go on, Lavanya ma'am.
It was very good, sir. It was like actually the day-to-day problems which we face while reporting. Like it is not direct case as Manoj sir told. these are the doubts which we have in routine reporting. So the discussion was really very good. Thank you, sir. Thank you all the Nandakumar sir, Manoj sir, and
Well done. Both of
Ramalakshmi
you
ma'am.
actually done excellently well. I mean,
Yeah, very nice. Very
yes.
nice.
Thank you, sir. Thank you.
Okay, Dr. Shikha, do you have anything to add?
Yes, sir. Very informative and very interesting session, and learned a lot. And with all the discussions, I think these are the cases which we get troubled by daily in our daily practice, and I really enjoyed being here. Thank you, sir.
On that note, I want to congratulate you on scoring the top mark today. Just after seeing the results.
Great,
So,
great.
Dr. Shikha has scored the top mark, followed by Dr. Vinod Kumar, maybe in the audience, and Dr. Anmol Godaga, who's got the third position. So those are the top 3 ranks. Well done, well done.
Thank you, sir.
Well,
Thank you.
Thank you,
congratulations.
sir.
Excellent, excellent, excellent.
Okay. So thank you, Glodama, and thank you for all the panelists for joining in. It's been a great, exhaustive discussion. Actually, I need a bit of rest after this.
Yeah.
After pathology. So hope everybody enjoyed. Thank you very much. Signing out.
Thank
Thank
you,
you,
sir.
sir. Thank
Thank
you,
you.
sir.
Very good.
Bye.
Bye. Bye.